Well, friends, colleagues, esteemed guests, welcome to the 2021 gLocal Solution Room Adelaide. That's worth a round of applause, right? Here we are, in person and online. A warm welcome to all of you who are watching on streaming services around the world as well. My name is Craig Lockwood. I'm your MC today. And whether you're online from Ethiopia or Kenya or Singapore or San Francisco, many of the other countries, you're a part of our solution room today, and we want to hear your voices in those chat rooms. So please be busy, communicate with us and connect. For those of you that are here face-to-face, what a rare opportunity to have an event together face-to-face where we can talk and get into the nitty-gritty of ideas and issues around clinical care. I would like to start by acknowledging that today's events take place on the traditional lands of the Kaurna people. I want to acknowledge the Kaurna people as the original custodians of the Adelaide Plains and the land on which the Adelaide University campuses are built. I acknowledge the custodians of the various lands on which you who are here today, in person or online, also work, particularly those of Aboriginal and Torres Strait Islander people who are participating in today. I pay my respects to elders past, present and emerging and celebrate the diversity of Aboriginal peoples and their divergent cultures. I would also like to give a special thanks to SA Health and Walters Kluwer Health as our sponsors and partners in today's event. Healthcare doesn't improve without partnership, whether it's in a distinct clinical setting or at a higher level, so we're grateful for these things. These acknowledgements are important because words matter. In fact, in the words of a Chilean biologist, Francesco Guardia, that is not pronounced correctly, don't look it up phonetically, he said, "The way to make a system more healthy is to reconnect it with more of itself." Now, being here today isn't because we think we have an unhealthy system, but it's because we want to reconnect and connect and be a contributor. The fact that you're here today means you have experience, you have motivation, and you now have opportunity to connect or to reconnect with our health system and contribute from an evidence-based perspective. You're in for a fantastic day. You've come here with questions, with problems, and perhaps challenges that you've encountered, and we're looking forward to dealing with those with you in a collaborative way. To get us kicked off this morning, our first speaker is Professor Zoe Jordan, and I've already forgotten that I'm meant to do this. And Zoe Jordan is going to open this event today and tell us a little bit about JBI. Do you want to come up while I chatter? Yep. To tell us a bit about JBI and the gLocal Solution Room. Zoe is the JBI Executive Director and has held numerous leadership positions over the past 20 years, working to promote and support evidence-based healthcare globally. Zoe is interested in the relationship between communication theory, engagement and translation science, particularly in relation to a global context. There's a lot more I could say, but it's better to let Zoe speak for herself. So please welcome Zoe to the podium.
Thank you. Thank you, Craig, for that introduction. And welcome to the third, I think it is, gLocal Solution Room. It started as just the Solution Room. I'll talk about that in a little moment. I'm delighted to be here in person. As Craig said, we're all so excited to actually be in a room together and hopefully to talk about some of the challenges around implementation and perhaps find some solutions. So it's such a rare occasion, as I said, as Craig said, to be in a room together as we Zoom ourselves remotely and have been doing for some time. But I'm very much old-fashioned when it comes to how we connect, and so it's a real privilege for me to be with you here today in person. I do also want to reiterate Craig's sentiments and to welcome those who are with us online. I'd like to also thank our sponsors, Walters Kluwer Health and SA Health, and also to thank our guest speakers who you're going to hear from shortly. Thank them for being here with us as well. So for those of you who are perhaps not as familiar with JBI, our vision and mission are to provide better evidence to achieve better outcomes and a brighter future. Our mission is not only to promote evidence-based healthcare, but also to support those trying to achieve it at the point of care. But we can't do that with just our little team of about 35 here in Adelaide. We work very closely in partnership with people around the world. Just to give you a little bit of background about this event, the idea of the Solution Room came from a powerful conference concept that aimed to engage and connect attendees and also to provide peer-supported advice on pressing issues. While this event doesn't follow strictly the concept, we really liked the idea and the pragmatism of pairing real-life challenges related to implementation and partnering with people to come up with some solutions. So they'll be learning on both sides of the podium, hopefully, today. We have JBI staff dotted around the room at tables who are really keen to interact with you. We haven't been able to do that in person for a very long time. And from our perspective, going back to our vision and mission, it's really important that we have opportunity to hear about what you're experiencing. So the event was originally designed to be exclusive to South Australia, but when we shared the concept with our international collaboration, they just loved this idea of connecting with people locally. And so the gLocal was born, and we now have 8 events running across 7 countries in addition to our event here today, both online and face-to-face, COVID permitting. So we're really excited that there's been such broad uptake of this around the world. Glocalisation was popularised by a gentleman, a sociologist called Roland Robertson, who traced the roots of the term back to a Japanese business term, which I will also get the pronunciation of probably wrong, dochakuka, which emphasises a global outlook adapting to local conditions. It stresses the idea of contemporary globalisation influencing the local level of society, but also vice versa. So what has this all got to do with evidence-based healthcare? You will see that the yellow wedge of the JBI model at the top speaks to both the globality and locality of evidence-based healthcare. The JBI model of evidence-based healthcare recognises first and foremost the critical relationship between research and practice. In simple terms, EBHC begins and ends with the needs of health professionals, of health services and of health service users. If we as researchers and synthesists are not engaged with the people who are using evidence, then we're never going to succeed at our end goal. So events like the gLocal Solution Room are really important ways of us determining what questions matter to you. What questions do you need us for us to help you to answer? And the fact that we have these events occurring in different contexts across the world, I think, speaks to the importance of that connection, that local connection informing the broader global agenda. In thinking about the application of evidence, obviously then, context is key. At JBI, we're cognisant that it's our responsibility not only to provide health professionals with the best international evidence, but also to support you to use it locally at the point of care. Again, that's not possible without connecting, without acknowledging and accepting that different cultures and clinical environments present different challenges. And we hope that this event, or rather this series of events, contributes to overcoming some of those barriers, to helping us understand the challenges that you're experiencing, and to provide an opportunity to co-create solutions together. I think it would be remiss of me to not talk about COVID in the current climate. No country or region has been spared throughout this pandemic. The crisis has really laid bare the stark weaknesses in almost every healthcare system. With and between countries, we've witnessed the disproportionate ability of health services to respond. We've also seen firsthand in real time both the successes and failures related to evidence implementation. To achieve a new normal, we keep hearing about this new normal, we're going to need a coordinated, coherent and cohesive response that is effective globally for sustainability. But that global approach will require local expertise to be successful. For decades to come, I'm sure that we will be reflecting critically on why some countries, some health services have been able to respond better than others to COVID. I suspect that at least in some instances, this will relate to how and whether, indeed, evidence was considered and utilised at a local level to make decisions. In the last 18 months, we've been it's almost been like a stress test for evidence-based healthcare, I think, in some respects. And there have been lots of lessons that we've learned in relation to how and when evidence is applied. The model of partnership that we employ with our global collaboration leverages the strengths and competencies of our global community. It really values difference and promotes equity and diversity and inclusivity. And I think when we're talking about having a gLocal approach, that's really important. This graphic that I've got on the screen now is something that I've borrowed from authors in the education space who speak about gLocal knowing, gLocal acting and gLocal being. That is the ability to contextualise different types of knowledge, to work together across cultural, social, national, geographical contexts to identify sustainable solutions. And what I like about it is the pragmatism of it, which is something that JBI has been really connected with since it was started. The way in which we connect in order to make meaningful decisions using the information that we have available to us. That's precisely what this event is all about. As I said at the start, I'm filled with warmth and gratitude that we're able to be in this room together with a group of this size. I'm very mindful that there are people who are perhaps joining us online overseas who are not in a position to do that. So I'm very grateful that we're able to be here together. I hope you enjoy the wonderful program that Craig and the rest of the team have put together for today. Again, thank you to our speakers and our sponsors, and I hope you enjoy the program. Thank you.
Thank you, Zoe. Yeah, look, it's my pleasure to introduce our first keynote speaker today, who is Professor Lesley Dwyer, who is the Chief Executive Officer of the Central Adelaide Local Health Network, which is a large quaternary multi-site campus based right here in Adelaide, South Australia. There is a lot on her CV, but I'm going to let Lesley introduce herself. Thank you very much, Lesley. Please welcome her to the podium.
Always have to just readjust the microphone for my height. I'm well used to that by now. Yes, there is a bit on my CV. My age is usually a dead giveaway that, you know, sort of I've been around for a little while. But I'm really delighted to be here today and really thank JBI for the invitation. I'd also, before I start, like to acknowledge that the land that we meet on today is the traditional land of the Kaurna people and pay my respects to their elders past, present and emerging. So as you can see, the topic that I'm going to speak to you about has got a very long title, which is Safety and Quality in an Evidence-Based Healthcare Culture, Organisational Leadership. As the Chief Executive of Central Adelaide, you would expect that I would probably talk a little bit about leadership. For those of you in the room and those of you that are Adelaideans, you know, sort of Central Adelaide is probably better known to you as the Royal Adelaide Hospital and the Queen Elizabeth Hospital, but we also have other sites as well, being Glenside and Hampstead. And in actual fact, there's a real strength in that multi-site approach and the diversity that we actually have, not just within the people that we provide care and services to, but also our staff. And so if I was to really sort of distill down what I do want to talk to you about, because our journey has been well, I think, reported or chronicled from, sort of being placed in corporate administration as a healthcare organisation 2.5 years ago, which is very unusual, not just unusual within the Australian context, but actually globally as well. But I actually want to start to sort of really, I think, pull apart around, despite the best evidence, why does that actually at times not stop you from, not failure, but I call it getting into a little bit of trouble where you are not able to advance the right thing to do. And it really comes down to what are the behaviours that we actually accept, what are some of the norms, but what are some of the changes that we can make to try and get people back to, sort of using evidence. And I was really, I think, taken by, sort of what Zoe had said around the glocalisation, and particularly that quote around that the context, the local context, is really important as well. I returned to Central Adelaide from the UK, and sort of I think everybody thought, oh, here we go, she's going to NHS, eyes us all. And in some ways I have, because evidence is evidence. And if you see something that's worked well, you do need to think about, well, what's our local context and what do we do? So that's what I actually plan on talking about. I'm always so grateful when that happens. So, I'm just going to talk a little bit about evidence, because as we know, sort of, and I've just spoken about, that despite the availability of evidence-based guidelines, there are significant gaps in implementing evidence into routine clinical practice. And it's just as sticky and difficult as when you actually want to see translation of research into practice. And so what is it that actually stops us doing that? And I often, when I'm talking to people, particularly if we've got, sort of something that, sort of is holding us back, I have to determine, am I listening to opinion? Am I listening potentially to eminence? Or am I really listening to evidence? And so we went and actually had a look at, sort of, well, what's some of the evidence sitting behind why you don't see that translation, that change, that, sort of implementation of evidence. And the Care Track Australia study, which was conducted to determine the percentage of healthcare encounters where adult Australians received appropriate care, the authors of that study suggested that without evidence of variations in care and poor compliance, we will always be unable to create sustainable systems. And most of us who work in health know that one of the things that we battle with is the constant starting, not quite finishing, starting on something else. We're very good at addressing a problem. We're sometimes not good at solving it because we're on to the next big thing. And so what that found was the appropriate care was provided really at only 57% of time of the encounters. And in fact, what Braithwaite et al. Identified was that only 60% of that care on average, so it is averages, is in line with evidence or consensus-based guidelines. 30% of care is of low value or waste, adding no value at all. And there's a bit of a change in the funding system within Australia, and certainly within South Australia in this next financial year. We will no longer be funded for where there is evidence-based low value care. You're going to have to put up an argument about why you think that your opinion, eminence or evidence is actually different. And so I welcome that, because it starts a very useful discourse. So that's something that we're really keen to do. So we call this our 60-30-10 challenge. Oops, keep going. The Care Track data, which showed us the variability, and I know that this is a little bit hard to see, but you can see where there are pockets of excellence, as you can with coronary artery disease being well managed, about 90% of the time. So often when you think about the problems you face, you think, who's done this before? And what were the various components that they're doing? What's the conversation that they're having? What's the evidence they're looking at? And what is that translation into practice that's allowed it to stick? And as we can see with coronary artery disease, it has been an area that I think has been well researched, well evidenced, and it probably says something about the culture there. But conversely, you can see that with asthma, which in Australia is a fairly common issue, health issue, patients being treated for asthma only receive appropriate care 38% of the time. And this is despite, and I know many of you will know about this, those asthma guidelines. People have been working on this for well and truly over a decade. And I think in the paediatric area, we've done extremely well, but not sure that we've done that so well for adults. So within our health service, sorry, there we go. Oh, see, I told you this is terrible for me. There we go. Phew. How do we improve on that 60% of time and have that impact on practice change? So the authors, as I said, of the Cares Track study suggested that continuous improvement based on ongoing monitoring of the appropriateness of care should really become part, of the healthcare, an intrinsic part. We audit lots of things. We audit care guidelines, we audit lots of things that are not in the care spectrum. But in fact, how are we going to make checking that we're using evidence, that we're actually also growing evidence, to actually, lead to a change of practice? And make sure that we monitor and feedback that evidence back to the clinical areas around where there is change. One of the things that I've observed over the years is most people actually don't want to not know how their competitor is going, and it's actually part of our psyche here as a nation as well. There is a little bit of competition, and it's not competition of shame. I live by some simple mantras in my professional life, which is, are we the best or are we the only? And my view is that if we're not the best, we need to partner with the best. And if we're the only, we better make sure we are the best. But how do you measure that? How do you look globally and say, who is doing this better? How can I get some uplift from that? And we think that it's actually logical. Most healthcare professionals are, educated. They're well trained. They are surrounded by other, logical people who are looking for evidence and reviewing their practice. And some professions do it better. But in fact, there is some evidence, which is that if healthcare practitioners were given feedback that what they were doing was inconsistent, that in actual fact they may change their own way of going about their care. But yet the evidence goes on to say that audit and feedback alone has not consistently been found to be effective. And so the Institute for Healthcare Improvement have developed a white paper around framework for safe, reliable and effective care in 2017. And what they've actually, in laying out that practical framework, have said that because culture and learning systems are both foundational to a framework for safe, reliable and effective care, it can be difficult to know or where to begin. And organisations need to have the culture to be able to do the learning and the need to do the learning to change the culture. Often when things go wrong in health, we're very good at doing that look back. But in actual fact, there's more learning about when you do that quick catch or when, in fact, you have been able to make a change and, in fact, you are learning from what goes right, not what goes wrong. And that's a real shift in culture for us. And so what we're wanting to actually do within the Central Adelaide is think about the leadership that we have. And that's leadership at all levels. When I talk about leadership, I don't talk about an executive role, and we have changed our structure so that we have got clinician leaders at all levels in that organisation, and that's something I'm actually really proud of. But in choosing those leaders, and I have a clinical background, and perhaps I got my first roles because I was a good clinician. Did that make me a good manager? Did that make me a good leader? Probably not. But thankfully, many of us have good role models and we go off and we actually try and, expand our skill set. But strong leadership is essential to drive and prioritise safety by facilitating, but also mentoring. Often when things go wrong or we're getting stuck somewhere, I say get alongside. Make sure we're actually alongside, but start to look for the evidence there. Because often we just jump in at everything, we try about 10 things, hopefully one of them will work. Very difficult then to go back and say, so which one made a difference? And it's not about a cookie-cutter approach. It's actually about using evidence, using those guidelines, because it's a very different thoughtful and considered discourse rather than I think we should, I have. It is around what does that tell us, how would we do that here? So for the purposes of this presentation, I'm going to focus on the impact of culture in becoming, often used, a highly reliable organisation. I always know that people within Central Adelaide get the best of care when they are in front of you. But what about the people who aren't in front of you? And what happens if that doesn't happen every time? And so being consistent is really important. There we go. So achieving that safe and high quality care requires well-designed systems and well-functioning teams, and it very much is around the teams. Without addressing a culture of poor behaviours and performance that can undermine team function, improve systems alone, we can change lots and lots of things, but unless you actually manage the way that the team works and really make sure that that is the primacy of all that we do, you're never ever going to change what often is a steady state of entrenched behaviours and cultures. There's been lots of reviews done, and I want to draw your attention to the third one there, which is from William Cooper. Bill Cooper is from the University of Tennessee, so Vanderbilt. In 2019, after a decade of looking at the impact of behaviour on outcomes and experience of patients, found a positive link between surgeons who had a higher number of co-worker reports about unprofessional behaviour and the risk of surgical and medical complications. In short, that in fact, if your behaviour is not as it needs to be, which is around working as part of the team, a bit like the airlines, we do expect that the co-pilot will say, Captain, I'm taking over the plane if you're heading for a crash. And we've put in lots of systems within health, and we've picked that up from aviation, but would you believe also from the motor industry, around, that reliability, that everybody has a role in that safety. And yet we've struggled yet again around what is accepted practice, surgical timeout. Can I say it happens 100% at Central Adelaide? No. But it's not an opt-in, opt-out. And what is the role of co-workers in saying, we're not starting, this is what we need to do? But what Cooper went on to find is that complication rates were also 14.3% higher for patients whose surgeon had 1 or 3 reports about poor behaviour, and compared with surgeons who had no co-worker reports. And this is when I describe it as somebody doesn't have your back. So you're off, you're in a bit of a, temper, or things haven't gone well. And yes, in healthcare, sometimes things, do stress people, but no one has had that person's back or given feedback to say, I think you're heading for a little bit of a disaster here. Gerald Hickson, who is the Senior Vice President for Quality, Safety and Risk at Vanderbilt, stated that even though there was only a 14% difference in adverse outcomes between patients being cared for by the most respectful and least respectful surgeons, if you took those numbers and distributed them across the US, where there are 27 million surgical procedures done every year, that could represent more than 350,000 surgical site infections, urinary tract infections, sepsis, all the things that we know that can be avoided when surgical teams work well together. And this has been repeated, not at those numbers, in the surveys that have happened, the numerous surveys across Australia about a poor behaviour culture in healthcare. And I just want to talk a little bit about that. It does get better. We do have a way forward, by the way. So the culture in the Australian healthcare environment, in 2015, the Royal Australasian College of Surgeons found that 49%, so just under half, of surgical fellows, trainees, international medical graduates had been subjected to discrimination, bullying, harassment or sexual harassment. And 2 years later, the College for Emergency Medicine, so these are our ED clinicians, found that 34% of its members had experienced bullying as part of their training. And there's been some fairly well publicised cases where trainees have been removed. And that doesn't just happen here, it actually happens across professions, but certainly in other countries as well. And so if we think about the South Australian experience, some of you will be aware that there was, sort of the Independent Commissioner Against Corruption, ICAC, in 2019, found that over 50% of South Australian health participants reported personally encountering bullying and harassment in the last 5 years. That report was actually titled Troubling Ambiguity. And so it's actually, well available on their website, and it makes a really interesting read around where, in fact, behaviour, sort of eminence, opinion, have really taken over what had been about good evidence and good teamwork. And the AMA Hospital Health Check found that, a wide range of doctors in training had personal experience of bullying or harassment. So to address psychological safety, we've identified the need to focus on team and organisational culture and the role that mentors and clinical directors, supervisors of training, play in supporting psychological safety. When we were first placed into administration, one of the very first groups that we established was a group called the Leaders Within. And these were people who would not have normally positional power, but they were the voice of what is actually happening out there, what happens in that direct patient interaction, what happens after hours. And they've really started to lead us into some really useful work that could happen. And we've also tapped into the work, and I do want to acknowledge the work that Michelle Tuckey from the University of South Australia has done in regard to role clarity, team function and avoidance of ambiguity as these drives dissent, which creates a substrate for conflict. And that her work reiterates that peer review processes are much more powerful than top-down approaches. So what we've done is that we have actually picked up the work that Vanderbilt has done, taking into account our context, because often when we're saying, well, what about this, they'll go, oh, it's not going to work here. And we've said we want to stop that. It's not that it won't work here, it's what do we need to know to fit our local context. And so we are setting about implementing the Vanderbilt, it's called Promoting Professionalism Framework. And it is actually about providing a safe process for reporting behaviours and concerns. But what it is based on is over a decade of evidence. So if I was to go to a group of clinicians and say, oh, by the way, we're going to teach you how to actually talk to somebody else about their poor behaviour, you can imagine how far that would get me. But what we go with is that evidence that I've already touched on about the impact that behaviour has with patient outcomes, patient experience, and equally as importantly, co-worker experience and the impact that we have on those who are joining our professions and coming through. And I'll just give you sort of where we have actually looked at, well, what are some of the things that we do, that we can actually look to? Because in fact, they found that if you implement this immediate feedback that just wants you to think about, that 71% of recipients who receive an intervention for a pattern-related behaviour were never ever named again, because nobody actually gets out of bed every morning to come to work and say, how can I make my co-worker's life a living misery? I'm sure they don't. Or how can I do something that potentially does not provide a better patient outcome? We know that. But in fact, sometimes life gets in the way, systems don't work well, and it's based on the premise that everybody wants to do a good job, and sometimes we don't think about the impact of our behaviour on others. Where this has been introduced around the world, in fact, hand hygiene, and I'm sorry to sort of take it down to something but it's so fundamental, and if anything COVID has taught us, that was probably something that kept us so safe, that where they have actually put this in place, the compliance went from 50% to 95%. So it was actually about our behaviour as doing those things that we know create a safe environment, doing those things that should be ritual, habit, and we don't even need to think about. And that compliance has stuck for more than 3 years, because you don't want to do these things that are just, sort of fly by night almost, and then you go on to the next thing. So the framework, it's actually around, I watch something happen, and then we do train people to be the messenger, because you don't take on the problem. But I might sit down next to that person and just say, well, Bill, I noticed that happened. But in fact, I think you might have, created some problems there, and I just want you to reflect on it. we've trained now over, I think it's about 25 people, so we have a good alumni. And you can see that there's a graduated pattern, and obviously if there's something is so fundamentally just the wrong thing to do, they call it the cup of coffee conversation, which is just have a cup of coffee. Where I've seen this introduced, I have to say the sales of coffee went down tremendously. Nobody wanted to have a cup of coffee with anybody, so you have to make sure you say what sort of cup of coffee it is. But in fact, those 4 levels of intervention, some people will immediately get to level 3 and they don't get to have a cup of coffee, they'll get something far stronger, sort of at that point. But in fact, it is very much about going back and looking at the evidence. So this isn't just, there may be, sort of an isolated report, but what you do is you look for patterns. You look at patterns through your safety learning system. So what incident reports have we had? What have we seen in the complaints that might be attributable to that unit, to that person? What is happening there? So you're pulling out evidence so that when you are able to have that conversation, the first one is just want you to reflect. The second one is, there are some patterns here, and Vanderbilt have shown over the years that those patterns may show that in fact, what we have is a colleague in distress. Not a bad person, but a colleague in distress, and it may not be work-related. And so we have partnered now with Vanderbilt about that. But the 4 levels are depicted in this slide. We have seen this. I've been fortunate enough to go to Vanderbilt, but I've also been fortunate to roll this out in another organisation. But in fact, sort of by putting this in place, as I said, 71% of people never get beyond the first cup of coffee. They've changed to tea or something. And you can see just the very small number that ever, by using this, proceed. Our HR processes, are there to protect everybody. But in actual fact, they are at times perhaps not really understanding what's sitting behind that. And from my perspective, what we need to do is has something that as we roll this out, we talk about the evidence. And because they've been collecting evidence for more than a decade, this is something that our clinicians are really engaged in, because nobody feels good after, sort of a terrible, terrible time, sort of in going through, a complaint that may be, sort of one that is actually signalling something that is much more distressing. So in summary, I think that it's really important that we do recognise by using evidence the impact of staff behaviours on a patient's safety culture and clinical practice. Leaders need to model what's expected and the standard to which we aspire, or as I often say, what we walk past we accept. We need to actually be looking at the evidence that we collect every day, but triangulating it to say, is there something else happening here? So patient outcomes, reported behaviours of concern, and the College of Surgeons have also picked this up and will be supporting us in rolling it out, and no, we're not just rolling it out to the surgeons. We think that this is going to be a positive way to start to change the conversation from you did something wrong to let's look at the evidence, let's actually understand what's sitting behind this, because in fact the patient outcome, the patient experience, your co-worker experience is something that is really, really important to us. So we're going to kick this off in July. We are going to be collecting evidence. We are going to be getting Vanderbilt to do that for us, because right now we want to actually get some leverage from others that have done this before. There are many places, sort of across Australia who have introduced parts of it. And one of the things that I'm really keen that we don't do, and, and it's not really flying in the face of what Zoe said about that, local context, is often things fail, despite the evidence base, when we take bits of them. And I'm a big fan, and as I said, I live from some very simple, almost, statements, which is lift and shift. Don't touch something that has a strong evidence base. Don't touch it for a couple of months. Watch it, quick catch if it's not working. But you might inadvertently take something out of that process that then makes it fall over. And so that's what we're going to be doing at Central Adelaide over the next little while. And this is what our ambition and our vision is at Central Adelaide. And it is very much about shaping the future of health with world-class care and world-class research. And when I saw, for Joanna Briggs, it is perfectly aligned. All of us are looking for the evidence that shows us how to do things better. that makes it easier for people to be their best selves. And we're hoping by looking at that evidence base around behaviour and outcome, addressing the behaviour, we're going to see a consistency in what we do. But more so, a place that is actually about believing that our staff do want to do the right things, and when things go a little bit amiss, we're there to support them, to have their back as colleagues. Thank you.
Oh, probably up here. Yeah. We do have time for one or two questions. If there are any from the floor, I just want to check in with you. No? Okay. Well, then thank Lesley one more time. I'll just move this up a little bit. I'd now like to welcome Professor Carolyn Miller, who is the Director of the Health Policy Centre based at Samari, to the stage. Carolyn is a NHMRC Emerging Leader, a Heart Foundation Future Leader, a Fellow and Beat Cancer Principal Research Fellow at the University of Adelaide, many other things as well. The centre that Carolyn runs delivers evidence to inform public health policy, health promotion, particularly to reduce preventable burden of non-communicable diseases. It undertakes programs of research in tobacco control, obesity prevention, and related to alcohol. Professor Carolyn Miller is actually most known for her work worldwide in public health for tobacco control, in which she has specialised for over 20 years. She was one of a select group of scientists who advised the government on the world-leading plain labelling for tobacco packaging that Australia has led on, and has many other accolades, awards and research programs to her name. Carolyn, please come to the stage, and please welcome Carolyn to her talk.
Thank you, and thank you for the invitation to speak. I'd also like to acknowledge that we're meeting on the traditional lands of the Kaurna people, pay my respects to elders past, present and any First Nations people participating today. So I'm more of a policy person and a non-communicable disease prevention person, but COVID has brought me more into the communicable disease and a little more into the healthcare space, which I'm going to talk about today. So at the Health Policy Centre, our core skills, as I've said, are around primary prevention. We bring to it training in psychology and economics, which really are both sciences of how to change human behaviour, just in different ways, plus public health and epidemiology skills, policy research, evidence synthesis. So one of the things I think that's sort of unusual about our centre is that we spend a lot of time working really closely with policy makers and advisors in a sort of, key trusted advisor sort of a role. So we do a lot of work providing evidence briefing for people who are in government and for elected officials to inform their real-time decision making. And so as people who work in healthcare settings as well as policy also understand decisions have to be made now, and they don't really have time for scientists to go on away and accumulate evidence, whereas people who work in academia understand, of course, that science has to be, constructed and built in a robust way, and that takes a long time. And so part of what we try to do is sort of bridge that gap between, the scientific work and world, as, like JBI does, and the real-time decision making. For us, it's about policymakers. And so the work that we've done has helped inform policy change, notably in tobacco control, population level interventions, and ultimately changes in behaviour. And we've seen that very clearly in tobacco control, particularly in Australia, less so in obesity and alcohol, which are our other fields of work. So when COVID came about, SAMRI offered, as did many other places, to assist, and one of the requests that came back from our Chief Public Health Officer was to provide a provide a way of accessing the evidence for her decision making and for the state's COVID task force decision making in a rapid way. So we brought our public health and our public health epidemiology and our evidence synthesis skills to the fore there, and then we brought also in specialist expertise in virology. So Steve Westling, who runs SAMRI, is a virologist and an infectious diseases physician, and then we brought in other people on different topics as we went. And what we produced was a service producing rapid synthesis of evidence, and so this involved us doing a rapid review of available evidence, which some of which was peer reviewed, much of which wasn't, and was in preprint or government reports, and sometimes even media statements. We would summarise and contextualise that for Australia, because our context here in Australia has been really significantly different to many other countries, and also point out the implications for policy, and then we would deliver that to our Chief Public Health Officer and our State Transition Committee. They would make policy decisions using that information as part of their decision-making process, and we would also, sometimes our work would go up to AHPPC, which is the federal equivalent. So we've done lots and lots of these, and I suppose they sort of fall into 5 big questions around COVID-19. So, what are the features of the virus? And these are still really relevant, actually, as we're dealing with variants. So how contagious is it? What are the mechanisms which lead it to spread? Which ones of those mechanisms are most important? Is it face-to-face contact? Is it surfaces? How does it present clinically? That was important very early on. What's the hospitalisation rate like? What's the case fatality rate like? Then how do we detect the virus? So what are the best, most effective, most sensitive and cost-effective mechanisms for testing? What symptoms should we be looking out for? How does contact tracing work, and what are the most important things within that? Then, of course, how do we control the spread? Lots of topics to cover there. Will our health system cope, which was really, our biggest question in the first instance. And actually, we've eliminated COVID essentially in Australia. And so this is less our conversation now, but very much was our conversation at the start, and I think will become our conversation again now that we're talking about opening up a little more. So, flattening the curve was a big issue at the time, which wasn't about eliminating COVID. Of course, it was about how do we keep our caseload going into our hospitals below the point of available ICU beds and ventilators. And we had PPE supply issues at the start, of course. So how do we make sure our demand doesn't outstrip our supply, because that's when the case fatality rate goes through the roof, which is what we saw in countries like Italy. And then, of course, what everyone's interested in, how do we safely open and recover economically? So the first topic that we did was schools and COVID. So we took this, every topic presents both a question of policy, which is, what should we do in the state around schools? Should we keep our schools open? And behind those questions of policy, there are questions of evidence. So the question of evidence was, what is the impact, or what do we think the impact of closing schools would be on transmission of COVID? So how important is it? What sort of level of impact would it make? And so what should we do? So this was at the start of the pandemic. There was lots of concern and unknowns about the mechanisms of transmission. There were modelling studies from overseas with very high media attention. And the Teachers Union in South Australia launched a campaign arguing for schools to be closed as well. So the published evidence was actually pretty limited to work from. There were studies of transmission that were peer-reviewed that indicated that children may be at lower risk of infection. It was very clear even then, and has continued to be clear, that children are less likely to become unwell. There's a very strong age relationship with severity of COVID, as people would understand. Mostly children who are infected are asymptomatic or have mild symptoms, and it appeared the case that transmission was possible, but children's propensity to transmit appeared to be low. So there were modelling studies. There was a lot of complexity in the modelling study literature, because a lot of modelling studies had effectiveness of closing schools as an input, as well as presenting it as an output in the findings. So we had to unpack that. Probably compelling at the time was a notable absence of data around children's transmission. So disproportionately low incidence, apparent lack of evidence of asymptomatic transmission, different to pre-symptomatic transmission at the time. Lack of transmission in schools despite cases in New South Wales. So it's a bit hard to see, but every sort of cluster up there represents a case that's been present in a school, and then the red indicates a case of onward transmission. So we were seeing lots of sort of cases popping up in and around schools, but an absence of transmission. And then we had information from New Zealand that said that transmission around schools related predominantly to adult events, so parents getting together rather than kids. So we put this together. So the other things we covered, which is sort of, I suppose, contextualising it in a policy setting, was also around potential consequences of closure. So what we knew about the impact potentially on kids' physical and social wellbeing, and also their safety. Home isn't a safe place for every child. Considerations around impact on the health workforce. So if we closed all the schools, what would happen to our health workforce's ability to come to work? And potentially, if older people were taking care of kids, then did that create a bigger risk beyond the risk of having the kids in school? So we did this 3 times to check the evidence 3 times for Nicola Spurrier, probably mostly because of the campaign of the teachers, and that evidence was used both in this state and also by AHPPC across Australia to keep public schools open. It also created an environment as a policy decision where parent choice was accommodated. So the school was open, kids could go to school. If parents didn't feel comfortable with that, online learning was accommodated. Okay, so the second example is around contact tracing. So the policy question was, when an outbreak occurs, what matters the most? So we've got this many contact tracers. If it starts to get out of hand, like it did in Victoria, can corners be cut, for want of a different term? Resourcing is always limited. What do we really need to focus on to get the return? And the other question that we were asked was, does contact tracing even really matter? And a lot of these questions were, how important is this intervention or that intervention in COVID control? So there was a lot more evidence around contact tracing. So we did it twice. We did it once for the state government, and then we did it once again for the federal national contact tracing review. So we had a lot of papers, and we also had international exemplars to draw on. So different countries who had different controls to Australia. For example, they may not have been using lockdowns, but they had very intense contact tracing. So contact tracing 2nd and 3rd generation contacts and quarantining those contacts, which is quite different to what we were doing in Australia. So we found that contact tracing is absolutely essential for COVID control, both contact tracing forward, so who a case speaks to, and trying to find out where the case came from, which might sound sort of obvious to us living in Australia, but not every country was doing that. We also found that contact tracing needs to occur at a pace, so you can get within 2 to 3 days, get about 80% of close contacts quarantined, then you can maintain control. On the other hand, if you're at 4+ days, or you can only get less than 60% of people in quarantine, that's when you lose control. So that's what the state health departments need to know. What are our KPIs, so we know we can keep the state open, and when do we think we're getting out of hand and we need to lock down? And really, a lot of hard lessons were learned in Victoria. Scalable workforce is important, so bringing in med students to build up your workforce when this sort of stuff starts to happen. Technology is hugely beneficial. We've got a pretty low appetite for this in Australia, but lots of countries in Asia do a lot more digital surveillance of their systems, and that's a really effective and powerful part of their contact tracing. And transmission's uneven as well. So we know that COVID, and we've learned all these things over time. We know that we've got a sort of like almost an 80-20 split on people who do transmit COVID a lot and people who really don't, in lines of transmissions that die out. But of course, you've got no way of knowing who those people are. So you just have to get everybody sort of isolated. So our work, so there was a national contact tracing review done. The author said that the summary evidence updates provided the scientific underpinning for the whole report, so there was no other group that could produce that work as quickly and as effectively as us, so they used our work and made recommendations which were absolutely in line with the work that we'd synthesised for them, so scalable workforce, attendance recording, which is of course our QR codes, and key metrics around getting close contacts quarantined really quickly. And that's what underpins our practice now. So just my third and final example is temperature screening. So the question was, what is the predictive value of temperature screening for COVID-19? That should be, of course. So the policy question there is screening temperature in public places worthwhile? So this was of interest for hospital entrances, retail. If you go to a Mac centre, you'll get your forehead screened. Aged care, should we be temperature screening aged care? And what about our airports? So this kind of broke down into, 5 different sort of questions, 5 different scientific questions. The first two, the first one is really how well does elevated temperature predict active cases of COVID-19? And that was the sort of first scientific question. And at the time, and I'm not sure that we're still publishing data on this at a federal level, but at the time, the prevalence of fever in a confirmed case of COVID was only 47%. So less than half of people who have COVID will present with a fever. And a cough, in fact, was a more prevalent symptom at the time at 69%. And of course, elevated temperature is not present in people who are pre-symptomatic. So firstly, we're only going to find half the cases if we screen, at best. So then the second question is, how good is temperature screening technology in detecting elevated temperature in screening settings as opposed to in a clinical setting? And the answer really is that the non-contact thermometers measure skin temperature, which isn't as good. They've got quite low sensitivity and low positive predictive value, and so they're not actually very good at accurately assessing temperature. In that sort of way, and also they were used very widely for SARS in different countries, including Singapore, and they weren't found to be effective in either picking up positive cases or, so accurately finding sort of positives and negatives. So the other considerations, of course, as medical people understand, temperature fluctuates, medication can mask it, probably better than self-report, might act as a deterrent to someone who's unwell entering a setting, so better than telling people to stay home if they don't feel well, might create a false sense of security. The sort of practicalities when you get into a health service setting might be, we've got questions of feasibility, infrastructure and cost. So you've got people sitting at the entrance to every hospital in the state, so you have to pay those people, you have to get that technology, you have to monitor everyone who comes through the door. What do you do when you have a positive temperature reading? So do you put them into secondary screening to make sure it's more sensitive? If you're in a retail setting, you can just say, sorry, you can't come in. If you're in a workplace, do you send that person home? Do you decide they need to go and have a positive test? They have to go and have a test before they can come back to work. So there's a lot of sort of, on-the-ground feasibility questions around that. And of course, so then, then the risks of screening versus the risks of finding a case are going to vary by setting. And so this is the policymaker's, decision, of course. So if you're in aged care, where having a positive case come in and not be detected is catastrophic, you might have a higher appetite for funding that intervention, even though it's not particularly sensitive. Airports have a lot of people there anyway. Hospitals and workplaces, I would say less good return on investment. So in terms of impact, Lesley's not here, so I can't check whether this is what determined what was done at the entrance to the Royal Adelaide Hospital, but we don't have temperature screening in our hospitals locally. There has been an enormous amount of media interest in this, and so we've done media work on this sort of, I think, kind of 3 or 4 times over the course of the year. So that's sort of been the impact there. So as I said, we've published, we've done more than 25 of these and published. We've done them on sort of almost every practical sort of policy question that you could imagine. Right now, most of our work is focused around watching and monitoring the real world effectiveness of vaccines. So, how much of an impact do they have on reducing cases? Quite a lot. Italy, about 2 days ago, published data that said it was about 80%. What about hospitalisations? We're looking at about 90% impact on hospitalisations, and then I think 95% impact on mortality. So really, really good, strong real-world data coming out of the UK, coming out of Israel, and coming out of Italy, places where they've done a lot of vaccination and a lot of monitoring. International students are a hotbed issue here as well, so we've been doing some work around that too. And they're all published on the SAMRI website if you're interested. So in terms of clinical settings, we did some of these at the very start. So we did one on ICU triage, so which people who come through the door are most likely to end up in ICU. We did one on what should be happening around COVID and pregnancy and breastfeeding and around cancer and immunocompromised people. But then Monash, I think, leads the National COVID-19 Evidence, Clinical Evidence Task Force, which we just partner in. So, and that's a much, much better setting than our setting. I think our strength is policy and their strength is clinical guidelines. So they produce clinical guidelines to an NHMRC standard on a whole range of different issues around COVID, and they've published those and made those available for health settings and clinicians. So a couple of other things we've collaborated on very briefly. There's been a national seroprevalence to try to get a sense of sort of the prevalence of antibodies in our community, to try to work out, we know how many cases we've identified, how many other people have produced antibodies that have been exposed, to give us a sense. So that work hasn't been published, but we probably expect it to be similar to other countries around the world that have published these sorts of results. So, that for every case we find, there's probably a reasonably substantial number of other cases, which in many ways is good news. And also we were doing work trying to determine the exact rate of childhood transmission in households, which became hard in Australia because we started putting people who had COVID into isolation, which was the right thing to do from a policy point of view, because households are actually the main driver of transmission. So in summary, people have to make these decisions against very tight timelines, and the decisions will be made and cannot wait. And we're in the middle of that at the moment. We've got a story on the front page of the Advertiser talking about hoteliers wanting to go to 100%. Putting a lot of pressure on our decision makers around vaccine rollout, and so that's the policy and evidence question that we're in the middle of right now. So our question is, what does the Chief Public Health Officer, Police Commissioner need to know to make those decisions? So we take the question that's a policy question, define the scientific question, do a rapid research for all potentially relevant information, review that evidence, the high quality evidence, the sort of medium quality evidence, the less high quality evidence across published, government, other sources. So we present the evidence and also the quality of the evidence so people understand that. Contextualise it for the Australian policymaker or the South Australian policymaker. Try to give them everything they need to know to inform the decision making, but we do not tell them what to do. So it's not our job to tell them what to do, it's just our job to help them to access that science and then deliver that within about the space of 1 or 2 weeks. So this is the team that's done work on it that I'd like to acknowledge, and thank you for your attention.
Thank you very much, Carolyn. Do we have some questions for Carolyn on this remarkable topic? Just while you're warming up your brain cells. I know you haven't had coffee for a while. Carolyn, this is really remarkable work. I was intrigued by your notion that there's a policy question and then you develop a scientific question. What's that like, trying to then get a consensus back with the people that want the evidence that these are the right scientific questions that relate to their policy?
Well, I think we ask them to define their question as precisely as they can, and then also explain I suppose informally to us, the policy decision-making position that they're in. And then we go away and go, well, these are probably, in many ways, we're sort of stepping out the logic to help them see they know what they have to do, but to sort of, from our point of view, this is a scientific question, here's the answer to that, here's another scientific question, here's the answer to that. This might be a more contextual question, like for schools, what will happen if we do close schools? This is what we know, this is what is evidence-based, this is what is speculation and opinion. And a lot of the time people, with COVID, there's a huge amount of opinion published in lots of really quality journals, and so you can go through and actually scope through some of that and say, here's four published opinions on this topic, and this is the strength of evidence that does or doesn't sit behind them. Yeah.
I guess thinking about the evidence, particularly when you get to, we want guidelines for clinical care decisions, such as should somebody get an ICU bed or not. I mean, that's a really big decision.
Yeah.
And how do you manage that? Were you working with clinical stakeholder groups, or do you reach a negotiated point with the evidence to feed into a guideline?
So we didn't write a guideline, so that's what the clinical evidence guideline people do. Yeah, that's the Monash group, right. And that's good because they do that in a much more systematic way. What we delivered, so the question that we were asked is, how can what are the predictors of ending up in ICU? And so that's what we did a review on. We did so this is every study that's been published in the world to date, where the end point has been ICU versus not ICU. Yeah, and went through. So there was a whole lot of things that were sort of demographic, age, gender, weight, actually have turned out to be really strong predictors of poor outcome with COVID. We listed all the clinical diagnostic tests because people were publishing all of those as well. And I think probably what we ended up delivering was something that really, I suppose reinforced what observations the clinicians who were on the ground in the settings were making as well, but gave them access. They don't have the time to review every paper that's been published around the world on the topic, so we gave them a synthesis of that.
Sorry, I'm not going to let you go yet. Any other questions? Thank you, Ed.
Just on your last slide there was that interesting snippet of the work that was around contextualising the evidence. And the example you used, the current question, restaurants open up to full capacity?
Yeah.
Now, the policy making that decision, that will seemingly have implications for health, for the business and their finances, for employment, and the list kind of goes on and on and on.
Yeah.
So how do you get that balance right when you're trying to deliver that? Is that a negotiation point for policymakers as well?
Yeah, I think mostly we're asked to focus around health. I'm trained in economics as well, so I would say I'm literate enough in economics to be able to provide some perspective on that. Sometimes we collaborate with economists. I've done some work for Queensland Health, which was a much bigger project where we had a sort of health stream and an economics stream working side by side to quantify that. I suppose, with the issue around should we be 75% or should we be 100%, it's a question of risk, isn't it, and risk management. So you can say we've got no COVID in the community, in the state, and we haven't had an outbreak for a long time, and that's how a lot of people will feel, and that's how the hotelier will feel. They'll say we shouldn't have any restrictions. And that's okay, except that in the event of a case, how many people are signing in, how many people have to go into lockdown. It's the same as Adelaide Oval. The compartmentalising, this many people check in, this many people would have to go into supervised quarantine, this many people would have to stay home. but we're not locking down the whole state. So it's a trade-off, I suppose. So the way we bring science, I mean, it's not our job to make the policy decision, but the way we bring science to that is we say, okay, well, this is what we know about how good the vaccines are. This is what we know about how good the vaccines are likely to be to prevent transmission. So we can use that to try to model when we can get to points where we won't have uncontrolled outbreaks or outbreaks that will overwhelm our health system. So we've got a community who sort of expect 0 cases. Then we've got the question of, well, what's going to overwhelm our hospitals and what's going to send our whole state into shutdown. So we look at the science, how the science emerges around vaccines, which is a protective mechanism. We know about contact tracing already, so that's how good is our compliance with contact tracing, and can we get 80% of people who are exposed in the event of a super spreader being present. And then we also know we have much different levels of risk around different physical and social settings. So we know environments where people, and that's based on where have we had clusters that have gone out of control around the world. So, you know, we know nightclubs lead to super spreading, and that's because of the way people behave in nightclubs. They're closed in, it's poorly ventilated, there's a lot of alcohol, there's a lot of physical contact. Same for weddings, you know, people know each other, they're having a great time, there's a lot of spitting and singing, and so these things lead to super spreader events, unfortunately. And if you don't have a super spreader, it's fine, but if you do, that's where you have to do your, that's where you have to do your contingency planning. So it's about appetite for risk, really, at the end of the day, because we're always, you're always kind of 14 days behind, I guess, because not every case comes forward and gets sick which is great, but it also means you might have 20 cases before you have a person that needs medical attention. And that's what happened with, the Parafield cluster as well, yeah.
Well, that's a superb, comprehensive answer. One more question at the back, please.
The question is that, as already mentioned, you guys wouldn't make any recommendations. Would there be anyone who would make recommendations, or you just present the evidence to the government and they will make the decision?
Yeah, they make the decision. And it's not our job to tell them what to decide, I suppose, because they, as I've said, we focus on evidence around COVID control. And as a government, they have to think about COVID control, they have to think about economic impact on the state, they have to think about social impact. So that's not our job. Our job is to tell them this is the weight of evidence to inform that decision. So we try to give them everything they need, but not tell them what to do, because, that's their role, not ours. Yeah.
There are a few systematic review experts in the room, and on their behalf, doing reviews in the future outside of the context of a pandemic, would you go for pre-publication preprints?
I don't think it's not preferable, clearly. I don't think and as we've moved through, I guess, we've sort of been less and less keen on including preprints, but at the same time, it's sort of hard to exclude them completely because it's such a rapid moving issue. Far from ideal, definitely, including a lot of preprints. This is why we're explicit about what the quality of each different
I thought that might trigger Ed.
Yeah.
Just a very quick one. We're talking about globals and contextualising. Is it part of your process to see someone else that there's answers to these questions?
Oh, absolutely. Yeah, absolutely. So, and there's a couple of, and we pick that up in our work. So there's a couple of groups. There's a group at Oxford who do a similar sort of a function. But I think actually, unfortunately, there's much less of this sort of work done than you might imagine. And I think a lot of it probably, it probably happens behind closed doors in a way. A lot of the work that's done federally, I don't think ever really gets published, and that's fine, the decision makers can all see it. But one of the things that we've been really pleased about is we give it to the policy makers and give them a couple of days to read it before we publish it, because we don't want it being in the advertiser before they've even had a chance to get to the end of the document. But we publish everything we do a few days after, and Nicola's been great about that as well. Part of that is about, well, why would everyone want to be doing this, It's such a waste of everybody's time and duplication of effort. And as the contact tracers review authors said, it saved them having to commission the work because we'd already sort of done it. Yeah.
Well, thank you very much, Carol. And what a wonderful. All right, it's time for some audience participation. No one knows about this because I only decided to do it right now. So, put your hand up like this if you're a clinician or if you are registered as a healthcare practitioner. All right, hands down. Put your hand up if you're in management or policy at a hospital or state or regional level. All right. Put your hand up if you're an academic from a university tertiary institution. Brian, you got 3 out of 3. That's bingo, mate. You win. Yeah, that's an interesting demographic thing for us. If you want 1 minute to stand up and shake it out because you've been sitting for a while, please do. Your 1 minute standing up. Brian was probably going to make you stand up anyway.
Actually, I might just do that. Oops, I've only got 30 minutes. I'm well pushed for time on my talk, but I might get to do one thing.
All right, I lied. It's not really a full minute. Sit down, sit down. I'm going to very briefly introduce Brian because he needs the time. He's a talker.
Irish.
Professor Brian Dolan, OBE, is a multi-award winning consultant. He's had a 40-year career as a clinician and academic and educator, a senior leader and an innovator across health systems and services. His passion is, I've lost myself, health system reform. And I don't think I can say a lot more that can't be better communicated by Brian himself. What a privilege to have you with us. Thank you, Brian.
Thank you very much. Thank you. So I'm just going to move these out the way, just move a bit of furniture. It was very apt, actually, that Craig got you to stand up, because actually I'm worrying about deconditioning. So we're going to talk about, for the next 4 or 5 hours, is around new ways of working for improved patient outcomes and experiences, but actually also about looking around care and the value and the importance of care in healthcare. And I'd like to acknowledge the traditional owners that we're meeting on the country of the Kaurna people, traditional owners and custodians of this land, pay respect to elders past, present and emerging, and recognise and respect their cultural heritage, beliefs and relationship with the land, and acknowledge that they are of continuing importance to the Kaurna people living today. Actually, I'm very intrigued that it's with a K but pronounced G. I checked this, but then I come from a country where BH in Irish is pronounced either V or W, depending which mood you're in. So I think we did it to confuse the English. You know, when it comes to this, what I'm going to talk around is, if you like, the emotion side of around the evidence and a whole bunch of things. But, you know, it takes courage. It takes courage to challenge. It takes courage to stand up outside the crowd. It takes courage to be wrong. And you know, for the 21st century, the illiterate won't be those who can't read and write. It'll be those who can't learn, unlearn, and relearn. That will be what 21st century illiteracy will be about. And it takes courage to speak up and speak against and be different. It also takes commitment to practice, to have the grit to endeavour. At the moment, I've spent last year, 2020 was not the International Year of the Nurse and Midwife that any of us expected, to be honest. But in a strange old way, I think it's been great for that. And it's been great because we would probably have spent a year patting ourselves under the back saying, geez, aren't we marvellous? But in fact, what we have shown the world is the critical importance of nursing in the health and public health space, and midwives as well. And I was quoted in The Economist last year, I think it was, and because I said, the public looks up to doctors. because, you know, doctors are fantastic. I worked in academic general practice for a number of years. You know, when I hesitated to put my hand up earlier, because I kind of see myself more as a recovering academic, to be honest. But, you know, the doctors are just outstanding people, but the public looks up to them. But they look in the eye of a nurse, because the dynamic, the relationship that the public has with nursing and nurses and midwives is a very different one from that which they have with our medical colleagues. They don't hang around most of the public in the social milieu of our medical colleagues. They don't necessarily know them socially, but there's a nurse on every street. It's a different space that nurses hold. And what I've been spending a lot of time in the last few months is how do we articulate and recalibrate the narrative? Because if our medical colleagues, if doctors are the stars, maybe nurses are the light. And maybe that's the best place for us to be, because not everyone needs to star. And something I learned a couple of months ago, which changed my whole way of thinking about stuff. I was having dinner, and a colleague was talking about Aboriginal people and some Aboriginal groups. And they don't look at the stars and look at the night and the light, the stars and join the dots, and you come up with Capricorn and Aries and the big cloud, the big dip and all that. What they come up with is they look at the darkness, and it's the darkness in which the shapes are found. So it's about how do we think and rethink the way we think about things. And it's also about connection. Change, evidence policy, it's also about connection. Knowing is not enough. It's about knowing how people feel and not underestimating how powerful fears are in preventing change happening. And when we're having conversation, recognizing that fear is a big, big driver of inertia and resistance. What if it goes wrong? What if it causes harm to patients? What if I get into trouble if I commit to doing this and it doesn't go right? What will happen if we tried it before and it doesn't work this time either? So recognizing that connection, and people are not necessarily resistance. Questions don't mean resistance. Often questions mean people are trying to process, understand, and overcome their fears. And when we go into conversations, it's about a process and a conversation founded on curiosity, not evidence. Because if the evidence was enough, we wouldn't be dealing with smoking, the anti-vax movement, all of that stuff. It's not enough to have the evidence. Lesley, before the thing we were chatting, she worked in one of the most outstanding CEOs I've ever worked with. I worked with Central Adelaide, local health network, Colin, as the critical friend for nursing. And there's so many great people there. But we were talking before the tea break. She was a CEO in a small town in the southeast of England, which had the highest rates of smoking among pregnant women. And what they found is after pregnancy, 78% of those women returned to smoking. So the intervention was not enough. So they took a different route, is they worked with the perceived matriarchs within those families and worked to connect them to enable smoking cessation. And that's how it changed. Not on the evidence, if you will, but around the relationships and the connections. Because culture doesn't change just because we want it to change. It changes when behavior and everyday reality changes. As a by the by, I'm really happy to share the slide deck with anyone here or around the world. You're very welcome to have it. If you hoard knowledge, it's wasted. Just give it away. Linda Holt and I, my business partner, she's also an emergency nurse by background like myself, we created the iCare program, standing for Innovation, Compassion, Attitude, Resilience and Engagement. And we've been running that program with 125 nursing leaders in Carlin, and we're now looking at a number of other places that are expressing interest in it, because it's how we frame this stuff. And this model, in fact, you can do a self-assessment based on where you are yourself on it, and we're building it up at the moment, this model of leadership. Because I think we need to recognize innovation matters, but compassion, I see the word compassion and think of the words compass and passion hidden in plain sight. Attitude coming from the old Italian for posture, how we present ourselves. Resilience is a muscle. We're not just born with it, but you build it. And engagement, as I've alluded to, in connection is how we connect with other people. You see, innovation is progress in the face of tradition. As David Divad Sanders says. But here was an innovator. Florence, she would have been 201 last week, haven't seen her for a while. And you know, she was extraordinary because she became quite literally a living legend in her own time. She was so perceived as so important in the fields of Scutari and the Crimea that even in the nights when she reduced the infection rate down from something like 42% to around 4%, you know, more people were dying as a consequence of infections than they were dying of battleground injuries. And she cleaned it up. She did, if you like, the global health, you know, sanitation, cleanliness, running water, all of those things mattered, and they are transferable even to today. But she was so potent when she walked around with her lamp that when she would walk past soldiers, if her shadow landed on them, they blessed themselves. She had that level of impact. She created the polar graph. I mean, the pie chart had only been invented a couple of decades before. She created an extension of that. First woman to become a fellow of the Royal Statistical Society. First woman to become one of the Order of Merit. Only 13 living people have that. An extraordinary woman in so many, many ways. But she also recognized something I dedicate so much of my life to, which is about valuing people's and patients' time. But it's extraordinary, the echoes all the way back from Hippocrates. It may seem a strange principle to enunciate that the first requirement in a hospital is that it should do the sick no harm. Hippocrates' dictum primum non nocere, first do no harm. It's extraordinary to me that, you know, we've for years and years and years have said, go to hospital, you'll be safe there. And now we're going about that. But she also said it's a well-known rule that keep no patient in hospital a day longer than is absolutely necessary. And even this may be days too long. The patient may have to recover not only from illness or injury, but from hospital itself. Hospitals are, you know, I've been told, and I don't know if this is accurate or true, but that the Royal Adelaide is the one of, if not the largest building in the Southern Hemisphere. And it strikes me that that is an indictment of healthcare globally when its largest building, or one of its largest buildings, is a cathedral of technocure. Because 90% of patient contacts happen in primary care, and yet we build, and you know, if you ever see the media, what they love is being in front of a hospital. Ideally, if there's an emergency department sign behind it, just to give a sense of, oh my gosh. You don't see them standing in the field saying, here I am in the community. You know, and we have a reconfigure what we think. But the most important element in healthcare, I think, to my mind, the connecting currency is time. So how do we maximize time? How do we minimize patients' wasted time and prioritize that? But it's axiomatic to value patient time, we must value staff time as well. And what I'd like to show you now is a very brief 70-second video, which the fabulous AV guys will put on now.
Over, the sky's about to show her the first glimpse of gold over waking up dreams. And thing is, I don't know why things that I felt so concerned with just let go and drift with the breeze. I've been running around looking for answers, and all of these days there still ain't enough. Like the moonlit late plains, let the questions just hang. All I need is time with your love. I've been running around looking for answers, and all of these days there still ain't enough. There ain't enough. Time with your love.
Now, if there was a little more time, what I'd be saying to you is, what I'd like you to do is have a conversation about what struck you about that, what emotions did it evoke, and what often comes out is people went, well, I don't know what I would feel about this, and did you notice, you know, and it's not just about young people, but the other feature around it is that all of those little scenes, it was only the very last one that somebody was in a hospital, because hopefully all of us in this room and around the world will live a life that's that big, but the amount of time we spend in a hospital setting is that big. And you know, full declaration, my son Will, Dolan and Asher Hardery's business partner, they are filmmakers and videographers, and I asked them to do this. It's called Your Last 1,000 Days. And you can find it on YouTube. But here's a question I'd like you to answer out loud, just to prove to the people listening around the world that there is actually people in the room. But this is the question I'd like you to answer out loud, and it's this. How many of your last 1,000 days would you choose to spend in hospital? What would that number be? Absolutely. Or actually, would you now like to join hands and contact the living, because we couldn't hear you? How many of your last 1,000 days would you choose to spend in hospital? 0. Absolutely. I was in Oxford some years ago, and I asked this question, and an occupational therapist said 3. And we said, well, why? She says, well, you know, because I'd want to make sure my medication, so, you know, 3 would be, you know, 1 would be better, 2 would be, you know, but 3, absolute. We loved her specificity. You know? But you're right, the answer for me, for most of us in the room, would be 0, or as few as possible. And I think if we really designed health systems around valuing time, we would have far smaller, fewer hospitals. We would rethink where we invest. We would rethink how we think about what patient experiences are like and where their care should be delivered. You see, there's only 2 days that are fewer than 24 hours in each lifetime, sitting like bookmarks astride our lives. One that we celebrate every year, and yet is the other that makes us see living as precious. And we long for love, we fear death, but we wish we had more time. And at 9 o'clock on the 99th day of the year, a 99-year-old died in his own bed, and his wife, who happened to be Queen Elizabeth, lay beside him, sat beside him. And it happened also to be my birthday. And it does strike me, you know, Prince Philip got what he wanted. He wanted to die in the place he called home, in his bed. Is that what you'd want for everyone? And as I understand it, only 14% of Australians die in the place they call home. In New Zealand, in the UK and other countries, it's around 28%. That is a number we need collectively to lift, because that is what the public wants just as much we want. And this is not about money, it's about doing the right thing because it is the right thing. Because time is what connects healthcare, not money. And when you think about it, access targets and waiting lists, how long you wait in A&E, how long you wait for an emergency department, how long you wait for surgery or outpatients, they're all measured in time. Beds are not capacity. Beds are simply pieces of furniture where people wait for things to happen. Capacity in a health system is senior clinical decision makers and senior clinical action takers. Because with the greatest respect, a new grad nurse or doctor or allied therapist, they cannot make decisions that progress the patient to the next stage of their journey. It needs senior clinicians. And it's manifest in language like, what are we waiting for? We're waiting for the registrar to review this patient. We're waiting for the clinical nurse specialist to see this really gnarly wound that we'd like her advice on. We're waiting for the physio to see if he can give us advice on this patient's respiratory challenges. It's senior decision makers that determine it. And harm is frequently caused as a consequence of time ill spent. There's the wonderful work of Drew Richardson in 2006 in Canberra, a huge sample size, where he found 40% of people who spend a protracted time in emergency departments, they've got a 40% higher rate of mortality and morbidity if they have a long wait in ED. Waiting is not passive. Waiting causes harm events. And at the opposite end of the spectrum, we've got people who are stranded in hospital, people who are 7 or super stranded over 21 days, and they're stranded patients with 5 things going on. They have got more than one medical team looking after them. They've got more than one therapy team looking after them. They've got multiple comorbidities. They have a long length of stay, and their predictor of the long length of stay is they have no plan, so there is a long length of stay. And it's a harm event. And one of the Singaporean studies found that 42% of protracted wait in hospitals related to deconditioning, the loss of muscle tone and everything else that goes around it. But it's not just our patients' time, it's our time as well. Running around looking for equipment. You're hunting down an OBS machine, and then you find two of them huddled together in the corner like survivors of the Titanic. And what have you done? You've wasted your time. Waiting for people to call back. And somebody else rings, and the person who did try to call you back gets an engaged number, and then they kind of give up, and the time is wasted. Something that I know doesn't happen in any health system, or in academia, anywhere on the planet, is being involved in pointless meetings. I know it doesn't happen. You know, wouldn't it be marvelous to say, I only go to pointful meetings myself? And 70 to 80% of global health systems, 70 to 80% of their budget is spent on time. Because salaries and wages are the purchase of the most precious thing we all have, which is our time. And that's where the health budget goes, on the purchase of time. And that's why it's a connecting currency. But you know, if you're working on a ward and the mornings go fly, and it's time to think, oh my gosh, look at that, it's 11 o'clock, not a child in the house washed yet. And yet, if your relative time comes dripping slow. But if you have a life-limiting condition, every moment becomes precious, because a minute feels like 10 minutes feels like half an hour, and a half an hour feels like an eternity. You see, care to me will always be more important than cure. Because while cure is limited, there's only so much cure we can offer anyone. Because we must in the end die. There's a point at which we are no longer able to be cured. But the need for care is infinite. From before we're born. In fact, there's the first 1,000 days, is the 2 years before and the first year of life. Through after our deaths, when we still need care in the dignity in our death. So while the need for cure is limited, the need for care is endless. And we don't have intensive cure units, we have intensive care units, and I think that's the reason why. You see, 3 reasons for valuing patients' time is, to my mind, it is the most important currency. And while our time is busy and important, our patients' time is sacred. 46% of people over the age of 85 will die within 1 year of a hospital admission. And a third of medical patients are in their last year of life. And if you had 1,000 days left to live, how many would you choose to spend in hospital? And the work of doing the AI care, I want to give you a case study of a fantastic nurse unit manager in St. Margaret's Hospital from this parish, Central Adelaide, and hers is about imagining applying the experience and the evidence around falls. And what they've done is they've created, for example, among a number of things, a falls tree and the falling leaves. And you can see they have the evidence around it, and they've done all the core stuff. They've cleared areas. They've checked what time the falls were occurring, and they were occurring where they were occurring was mainly towards the toilet. So they've introduced intentional rounding to make sure people are going to the bathroom regularly. They have created a whole good space, but that's the evidence. And let's be honest, the corporeal body of evidence around falls is pretty replete. It's not suffering from anorexia. You know, that is part of our work. And I'm talking next week, so far it's about 230 falls prevention folk registered on a webinar I'm going to be giving next week across the UK. And I feel like Daniel heading into a whole bunch of lines, because I'm going to be saying to them, falls prevention is the wrong term. Because that is a deficit model of thinking. What we really should be talking about is safer mobility. Because what is the one thing that's guaranteed to happen if you say to a child, don't drop that ice cream? You know, so we're always going to drop the, because we process the negative. And I couldn't do, you couldn't have a session at the JBI without mentioning great old Abraham Maslow. We're so busy worrying about keeping them safe, we forget about the self-actualization. But in the context of falls, the power of this, and they're checking when is their last fall, and when somebody does fall, they have a fallen leaf. And the power of that metaphor is engaged staff so much that the last thing they want is to have a falling leaf on their unit. Where it has led them to, very quickly, is they are reducing their falls by 1/3 and are on track to reduce costs by $600,000. And this is only about 3 months in. Because it's not just about the minds, it's hearts and minds in that order for a reason. First we connect emotionally, and then we apply the post hoc rationalization to adjust what we know is right in our hearts. But what we too often have are these battlefield metaphors of the body. We have the war against, insert condition here, COVID, heart disease, cancer. We have battling disease, we are fighting infection, we have aggressive treatments and immune defenses. We turn patients into a battleground on which we wage war on their bodies. They come in as a person, then they turn into a patient. And if despite everything we do to them, they are compliant and quiet and stoic and they go to meet their maker, what do we call them? Brave. And I really have a problem with this construct of brave patients. Cancer killed both my parents and my best friend. It wasn't or not whether they were brave. We shouldn't turn brave into a moral judgment about people's strengths as an individual, because one in particular, my best friend, he was terrified all the way through, and Mark lasted about 1,000 days. He is represented, that film is dedicated to him. He is representing those three teenagers having the crack, the Irish variety, on the couch. You know, we need to be aware that our language is weighted, and in its weighting, we need to be mindful that what we use as normal trip-of-the-tongue language carries a different weight. Look at failure, heart failure, kidney failure, liver failure. Person goes home, they tell me, I've got heart failure, I could die any second. Failed discharge. But if somebody gets home for 2 days with their grandchildren and it's the last time they've seen them, that is no failure to them. Our language really, really matters. And there's also the language of the front line. There is no front line because that infers there's a back line that doesn't matter as much. But I do know from living through the earthquakes in Christchurch over the decade and the shootings a couple of years ago, there is no them, there is only us. But also the problem of front line is putting people for the first time in generations into a place where they may end up as collateral damage. And they go home to loved ones who may become collateral damage. They become casualties in a war against. And it induces fear. And it is not helpful because it diminishes the value of the people like here. And you may not touch the hands of patients, but you absolutely touch the hands of those who touch the hands of patients. You matter. And being mindful of our language in terms of demographic time bombs and the tsunami of aging as if we're waiting for them to wash across the shores. The acopia. Most people I know who are older are suffering more from aphasia than acopia. The language of suffering from dementia. A person may be living a life of their construct and be quite happy. Why do we imply it's a sufferance? The word patient comes from I think it's Old Latin, to suffer. Actually, when you think about it, patients are called patients because they need to be, they wait so long. But also frailty from the medieval. It's why they don't like the word frailty, because it infers fragile and poor morals. See, maybe we need to rethink how we think. And that includes moving away from falls prevention to safer mobility. Instead of thinking about cleaners, we need to think about patient safety associates, because their real job is keeping patients and staff safe. And what do you think that would do to someone if they went home and said, they changed my job title and look at who I am now? Isn't that something? I am now even more purposeful. Instead of talking about reducing length of stay, maybe we should talk about giving patients back time. Instead of days in hospital, it's days away from home. Instead of hospital in the home, acknowledging that there's no ward like home. No matter how good, how compassionate, how caring and kind we are, there is no bed like your own bed. There's no home like your own home. You see, have you ever wondered why it's called ICU now, you know? Because what do we do to people? We put them in the most horrible, disadvantaging, disempowering, awful, unquestionable desperation of a place. And you know, how would you fancy if we did this with our undergrads? You know? See, Liz Lisa Morton, forgive me, and Nicola Cogan, 2 psychologists, have done the most outstanding work looking at what does it mean to individuals. And they've had the sense that the gown embodies this sick role. They become physically and emotionally vulnerable. It's relinquishing control to the health professionals. But if you are 80 and you spend a week in a hospital bed, you will lose 20% of quads power, 1.5 kilos of muscle mass, most of that going from your thighs and your hips, and 10% of aerobic capacity. But what do? We say, oh, but the person isn't safe, we need to keep them in bed. Without bad intent, we do great harm. But the thing is, if we risk nothing, our patients risk everything because they have a ringside seat to their own safety. But you know, there's a fantastic physio at Health Physio, and you know, he talks about falls are often thought to be a problem of mobility, but it's not. It's a problem of immobility. It's mobilizing patients is what we need to do. And remember, it just takes one person. It just takes one person who's not willing to put up with it any longer, who sits on the bus on the 1st of December 1955, and when James Blake, the bus driver, said, "Go to the back of the bus," she said no. And this 42-year-old seamstress, this quiet introvert, said no, and she lit the spark of what became the civil rights movement. And where she sat down, within hours, hundreds were outside that jail in Montgomery, Alabama. And one of those got involved was a young black Baptist minister called Dr. Martin Luther King. And within a few years, where she sat down and then hundreds marched, hundreds of thousands marched. And they marched because they believed in what he believed. And he didn't talk about, he talked about his dream, about what he believed in. He looked forward to the day when his 4 black daughters could play with 4 white children. They'd be judged not on the color of their skin, but on the content of their character. He looked forward to the day when the sons of slaves and the sons of slave owners could sit around the table and break bread together as brothers and sisters. He talked about the arc of history is long but bends towards justice, but not in a straight line. And as we saw for the previous 4 years in the United States, that was an arc that seemed to go quite wobbly for a while. And we have to acknowledge that it takes courage, it takes commitment, it takes passion, it takes connection. And it's also about realizing, and I know David is coming in from California, and I'm going to be speaking later about, he's going to be speaking later, I should say. But I was doing a piece of work, a commentary for a book that'll come out later in the year. And it was about this fantastic character called Ma Jode. And Ma Jode was in the Grapes of Wrath, and she became not just the matriarch, she was the symbol of wisdom and age, as they traveled from the Dust Bowl of the Midwest in an all too recognizable climate-affected, economically destroyed Midwest, and they were going to California for what they hoped would be a better life. And what Ma Jode says is, far away in the distance, the 1,000 lives we could have led are waiting for us to show up. But when we get there, it'll only have been one of them. And each of us could have chosen a very different life. Each of us could have chosen lives where we wouldn't have had to work as hard, give up weekends, study for years, not be available to things we loved. We could have chosen lives where we could have worked less hard for more money, walk out at 5 o'clock and forget the place till Monday at 9. But instead, we collectively chose a life of service. We chose to be part of something so much bigger than all of us. And we chose, in many ways, we became social millionaires, because there's some people who are so poor that all they have is money. But social millionaires are people who value people's dignity, their time, their autonomy. They are people who are passionate about wanting to make a difference in their small way. They are people who remember why we came into academia and healthcare. Those are the great days. And when we look back on our own last 1,000 days, we'll all probably say, you know, I never got rich or famous, but I mattered. I mattered to my family, I mattered to my community, I matched it to a profession I was so proud to be part of. And I think if you could look back on that and say, you know what, I was a social millionaire. I made a difference. And the place I leave behind is a little bit better because of the life I led. That's the life of a social millionaire. And it's not they that stop us, it's ourselves. Because as that great Kiwi, Edmund Hillary, said, it's not the mountain we conquer, but ourselves. And thank you for your time.
Stick around for a minute, Brian.
Or loiter with intent.
Do we have any questions for Brian?
I'll be heckling you all after lunch as well, apparently.
Yeah. We are going to break in a minute, so if you're online, feel free to take a break. We'll be back in 45. Before you go away, we in JBI is the host of this event in Adelaide, plus all the glocals around the world that are occurring over this week. We talk about evidence-based healthcare as being founded on clinical expertise, the best available evidence, and informed by patient preferences, values, and ethics, essentially. How do we amplify the patient experience within this mode of thinking? Because academics, admit it, you want the evidence and the skills and knowledge in the evidence, right? How do we help bring that patient component to the fore in our thinking about what is evidence-based healthcare?
I think my answer, and there'll be many, would be start with the patient and work backwards. And you won't go too far wrong.
I love a pithy answer. My old prof used to say, a pithy answer is the hallmark of academic excellence. But that's indeed beyond the call of duty. Thank you very much, Brian.
Thank you so much.
What a pleasure. Right, we are breaking for lunch and we'll reconvene in 45 minutes at 12:45. We're going to reconvene on time so that we can provide appropriate care to our online audience today. Have a good break, enjoy lunch, and we'll see you back here soon for Q&A. Thank you. All right, everybody, it's great to hear those conversations. I'm glad you've been enjoying those. Because we are synchronised live across the world, we need to get back onto our program. I'm going to invite our speakers to come up and join me on stage in one of these deluxe comfy chairs, and also Dr. Kylie Porritt to come and join us on stage as a specialist in implementation science to help walk us through this next Q&A panel session. As we prepare for this panel Q&A, if you're watching live from somewhere, then feel free to participate by putting your questions in on whatever live streaming service you've logged in through. People are monitoring those, so please come up, take a seat, and they will ensure your questions get through to us as well. So we're really looking forward to this as a dynamic, opportune session. And I was going to pinch that book. And a way to engage further in some of these kinds of topics. Equally, if you're here, we have some roving microphones and we'll be able to throw to you for that. The Q&A panel is where we truly fire up the solution room and begin to address the problems of getting evidence into practice. This morning we heard different aspects about evidence implementation from experts in the field across core domains, and you caught that this morning, right? These are critical domains in the health service. We've looked at and heard about from clinical leadership, from policy and the nexus between policy and administration and research, and from Brian, a very compelling talk about the human side of the healthcare service and system. So now we're going to also be joined not only by Dr. Kylie Porritt, who's a core member, a senior member of staff of JBI, but also by some of our colleagues from overseas. I'd first like to welcome, I think they're going to appear on screen behind me any minute now. So we're first joined by Dr. Kate Kynock, a registered nurse with 20 years of critical care nursing background, significant experience in evidence-based healthcare. She is the statewide knowledge translation manager for Mater Health and the director of the Queensland Centre for Evidence-Based Nursing and Midwifery, a JBI Centre of Excellence. Pleasure to have you with us, Kate.
Thanks, Greg.
Almost as famous, but more beardly for sure, is Adam Cooper, who's the... Sorry, I should stay on script, shouldn't I? He's the Director of Nursing Continuous Improvement and the Director of Affiliate Nursing Quality at the University of California, San Francisco. Just give us a wave, Adam, so we know you're awake. Yep. So Adam is also the Director of the UCSF Centre for Evidence Synthesis and Implementation, a JBI Centre of Excellence. His clinical care background was adult critical care with many years of experience in evidence-based practice, and we are privileged to have him join with us. You would say this is not a user-friendly time for someone in California to join an event in Adelaide. So with that warm welcome to you, it's now over to talking through and answering some of these questions. I'm just going to get into a comfy chair. We're all, you can hear us? Okay. Yeah. So when you registered for this event, you were asked two questions. The first question was, do you have a question about implementation? And the second question that everybody was asked was, what about barriers and challenges that you've come across? What are some of those? So we're going to start with a question that came from that registration process. I'm going to ask for your views and opinions about that. And then after that first question, I want to open it to you who are here today to see if you have any additional questions you'd like to ask. And we'll just go with the flow, however that happens to be. The first question is really rather broad. What are strategies to implement evidence-based healthcare? This is actually from the Director of Research at a university in the country of Chile. who's part of the live stream, I believe, today. But he's asking, what are strategies to facilitate implementing evidence-based healthcare? I think it's a very broad question, and I wonder if we can just change it a little bit, because it crosses clinical domains, it crosses policy, research and consumers. So I wonder if it might be easier for us to grasp a question like, what low-hanging fruit clinical practice? Kylie, I want to start by asking you.
Okay. Look, I think probably the simple answer is there's probably not one particular strategy that that will help with that. So I think it's whatever implementation strategy you use, it's going to have to be sort of multi-component. And I think it's very similar to the things that we've been listening to today. It's about getting people engaged. So I think at the very beginning you have to have buy-in from everybody to want to be able to want to change practice. You have to be able to have leadership to lead them through that change practice. And I guess the support as well, there needs to be that supportive network to be able to sustain that change practice as well. So.
Carolyn, you've had some remarkable experience of engagement.
Definitely around policy. I mean, I suppose what I would say for evidence-based policy change is that one of the things that we try to do is meet policymakers where they live. And they live in a world of political constraints, public discussion around any decisions that are made, ministers with lesser and greater appetites for change. So one of the things we try to do is consistently build relationships and trust, and consistently sort of present bodies of evidence, but also help them access evidence quickly when they need it and help them find the low-hanging fruit. So sometimes we talk about big aspirational end goals, but then also work with policymakers where they are in the small opportunities where they can see and bring about change without just working with them in the practical space of political and financial constraints. Yeah.
So have the big picture view, but don't forget the immediate landscape.
Yeah, be a trusted advisor that isn't going to. I think policymakers are often very wary of political consequences of actions, and I think working in a way that is sensitive to that and timely and responsive, I guess, is how we've.
Terrific. I'm coming to Brian. Do you want to input on low-hanging fruit?
I think picking up that point is you meet people where they are and bring them towards you. But you need to understand what is the space they are living in right now. But you can't just keep throwing facts at them. It's like saying, if I shout louder, they'll learn English. It's not exactly a well-known strategy of effective communication. Yeah. So you have to know where they're at and connect emotionally and build trust. So all strategies tend to be so dry they're almost desiccated, which means that we end up using language that doesn't exactly clarify, it obfuscates, and people get lost. The first time, it was almost like panels like this, and there was two people, really amazing, really outstanding nurse academics, and it was one of the very, very first times I'd ever been to one of these, and it was back when God was still a boy, so it was a long time ago. And they talked about qualitative and quantitative research, and I was thinking, oh my God, I've no idea what they're talking about. I just didn't know. And that's the challenge we face in terms of the strategy, is the language around the strategy needs to be clear, it needs to be plain language. I'm really proud to be a nurse, but every time I'd have a patient at triage, I'd say, what's the story? Because people present with a story. Our job is to interpret its meaning for them and a meaning for us. So a strategy, I think, just the low-hanging fruit is understand what the story is that you want to tell. Yeah. What is the story that people are telling themselves, and how can you bring those two narratives together?
Yeah, thank you. Now, Kate and Adam, for those of you that are in the room that might not know them, both have really extensive experience at coordinating and facilitating implementation. So, Kate, the question was, what low-hanging fruit would help accelerate the implementation of change in clinical practice? Do you want to chip in?
Yeah, thanks, Craig. I guess for us, where there is inconsistencies in care is the low-hanging fruit for us. So where there's data to show that there's that inconsistency, and also a big driver for us for change in, you know, the local healthcare context, as well as about patient experience. So, you know, where there's negative patient experience, that's really an area where we're able to get leadership's attention and be able to use that, to leverage off that, and to say we need to look at the evidence and what we can implement here. And anything that has a financial incentive as well. So where we're going to be able to show that there's a cost benefit to the organisation, again, that's when we're going to get a lot of buy-in at all levels of the organisation in terms of change. So that's some of our strategies that we would use.
Thanks, Kate. And Adam, what are your thoughts about low-hanging fruit?
Yeah, absolutely. And hey, everyone, it's great to be part of this dialogue. I completely agree with everything that was just said. And often we utilize data like Kate was just mentioning, but ensuring that the data that we're presenting is valuable to the group that is going to be experiencing any type of change. Along with that, in terms of potential low-hanging fruit, which I'm defining as some of the easy wins, some of the stuff we're talking about may be a little bit more complicated, but some of the easier things are making sure everyone understands what they have access to in terms of evidence, right? What do they have accessible to them? How easily can they access potential best practice related things to the types of practice in their area? And Kylie mentioned earlier about the importance of leaders, and we have found that that is crucial in terms of trying to implement an evidence-based practice within an organization and within a local unit. And it's not just supporting the change, but it's really modeling it. It's using the words, it's using, you know, hey, according to this recent systematic review, I just saw that blah, 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 blah. Or I just read this implementation report or project that stated in our area, the outcomes could improve by, and starting to really model what it's like to have a culture that's based on evidence.
Okay, thank you, Adam. That's a really interesting cascade of answers, isn't it? But they're different perspectives, but they're all filling out key components, really, that help us understand the same thing. Leadership, the nexus between policy and how that engages, flipping it and looking at it from a patient perspective and what are the drivers behind language around patients, and then what are some of those qualitative metrics in the way care is provided and how do we understand them? How do we see inconsistency and consider that as part of the low-hanging fruit, as Kate mentioned? That's really helpful. So the next question is actually from Uganda. I think we'll get to Australia eventually, but this one is from Soroti University in Uganda, and it's a little bit similar, and that's a common theme here is, you know, what are the best strategies for interacting with policy managers in order for them to buy in or accept that there is a need for change when one exists? And Carolyn, I'm going to throw to you first because of your extensive work with policy.
Yeah, I think it's, you know, first and foremost, you point out the difficulty in health, the issue in health or the need in health. But I think you move quickly on from that to other areas. So this can, you know, you demonstrate the economic case. That's incredibly powerful in policy settings, and that's also obviously incredibly powerful in health service settings as well. And I think, as you know, as you've said, you don't just keep throwing facts at people. You you try to understand from them what is it, what are the questions that you need the answers to in order, so if we have a shared agenda around fixing something, and we usually do, what are the questions you need answers to? So what does your CEO or your minister or whatever need to understand in order to resolve this? And what are the other, competing drivers that we can, provide answers to? Or it's just working within that space where they are, working within their reality, as opposed to coming at it from an academic headset and going, well, this is obvious and this is rational, because it's just nowhere near enough. And I think the other thing to say is that, we attention raise a lot in public health around different issues, but we also have to, if we get attention, we have to have the solutions right there and ready as well. There's no time for solution finding. The solution has to be, the pragmatic solution has to be ready, the tangible pragmatic solution has to be ready alongside the raising of the problem. Yeah.
It's a little bit ad hoc to ask this, but how frequently would you say that kind of response does get to a policy maker?
Well, I think, in tobacco control, we've been doing that sort of consistently for 30 years, and we've achieved, gradually, but we've achieved a lot, and now we're sort of amongst one of the world leaders in tobacco control and smoking rates in the world. I'd say in other areas of chronic disease prevention, like diet, we're not really we haven't done very well in Australia around that. There's a long way to go. And I think with the COVID work, that's been really productive and really helpful, and that's because I think we've come in, delivered something in the time frame that was needed, and built a relationship of trust, but also had a decision maker who was very, very oriented to best evidence as well. Yeah.
And I think you've got a strong, clear relationship with policy makers and policy leaders in South Australia that helps, this is a bridge that's come from both sides of the river.
Yeah, that's right.
Your side plus their side, and it's met very effectively in the middle.
Yeah, and it's hard when you're an academic, because it's not what you're rewarded for. You're rewarded for papers and grants. And so I think that's part of what's wrong with the system of academia, that it's starting to value impact, but it hasn't really. So it's a sort of it's been a low value activity, which makes it hard to do. Yeah.
And I think if you're in the room as a junior or aspiring academic, then these are interesting questions, because it's easy to feel passionate about a topic or a problem and think, I really strongly believe in this, therefore this is a priority. That's not always the case, is it?
No, it's rarely the case.
Yeah.
Especially if, political decision makers elected officials work on a completely different timeline to us. And I think the economic case is, they might be very sympathetic to what you think, but the Treasurer might not, and the Premier might not, and that's where the economic case. And the short term, for public health, the short term impact on hospitalisations, which is what, demand on tertiary services, obviously is a big driver.
It does come down to communication really as well. Like if you're having to communicate on multiple levels, communicating upwards to policy, but then communicating down and finding that consistent language, which is what you were talking about, is so that we might come from, as academics, we might come with a certain view, but to change our language so it's meaningful to the group of people we're talking to, I think is really important.
Absolutely. I'm sure, Brian, you have some thoughts about this, about the nature of communication with policymakers to help enable practice change, those sorts of things?
Yeah, so I've worked with policymakers in a number of different jurisdictions, and I think there's a couple of things to recognise. First, they're human beings, so they're venal, they're ego-driven, they can be selfish, they're just people being people, and it's not always about the evidence. So I think the first thing you do is make sure you build, as you've clearly done, build a relationship. Google them, find out about them. Don't go onto LinkedIn because they'll find out that you've been on LinkedIn, you've been stalking them. Just be wary of that. Just choose how you Google. But it is all about the relationship. That's the important stuff. But sometimes there's a timing issue as well. So the End PJ Paralysis campaign, we've known since the 1940s that deconditioning, the loss of muscle and a whole bunch of things, we've known that since 1947, before the NHS was founded, that it was a problem. The Dangers of Going to Bed was one of the 20 most influential papers in the BMJ of the 20th century. 70, 80 years on. And I know other groups like the gerontological folk, they've been pushing this, but the timing was right. It actually started, by the way, in Broken Hill in New South Wales in the outback. That's where the campaign was born. But it was also about a chief nursing officer for England's Jane Cummings, who I'd known for quite some time. She took up the mantle and ran with it. And when you have somebody who's passionate about stuff and you've got a great relationship with a policymaker, that's when some of the magic happens. Interestingly, a good friend of mine who was involved in all this, Pete Gordon, he got contacted, he works in this NHS system, and he got contacted by one of the senior NHS leaders say, oh, where's the budget centre for this whole campaign? He just laughed at, there is no budget. It's actually a bunch of people doing the right thing, which is informing policy. And that's the other thing I would say is, when it comes to policy, it isn't about the money, because sometimes money counterintuitively can stifle innovation. What's changing in smoking is the attitudes and the culture and all of those things informed by the evidence. But for youngsters, smoking just isn't cool anymore. No teenager wants to snog a smoker. That was as much about it as anything else. So it isn't only about the money.
Yeah. I think we've just discovered how to change teenager behaviour. Here on Q&A. We're solving everything today. How awesome is that?
Would you snog this person? That's why menthol cigarettes are being banned in the States, I think.
That's probably right. Now, Kate, you work across, if I can phrase this carefully, somewhat bureaucratic systems in Queensland. Not of your creation, obviously, but you work very effectively across hospitals, organisations and systems to facilitate implementation. Is there an element of negotiation with policymakers within that context that could be helpful for us today in thinking about interaction with policy managers to get buy-in or uptake on wanting to change practice?
Yeah, I think you're right, Craig. We now have a very complex system where we work across multiple public and private facilities, across a very large geographical spread across Queensland. Some of our facilities, they have, there's 1,200 kilometres between sites. And some of the challenges that come with that from a local policy perspective is we have all of these different facilities with their different policies and procedures and approaches, and we're trying to bring them under one sort of statewide system and approach to that. And that can be really challenging from a EBP and an implementation perspective, because we have such differing level of knowledge as well across those different facilities. And in terms of engaging with our policy managers and our staff, we really have to know our particular audience and what that level of knowledge and skill is from a EBP perspective, because we have some sites where we still are going back to having local policies and procedures which are just what we've always done. And I know we've come a long way in moving away from that, but from a local health perspective, that still does occur. So we have to be really aware of how we approach these different areas to bring them on that journey. So we have to be really adaptable in terms of how we approach that. And from, engaging leadership and the people involved in developing policy across our organisation, some of our strategies are around sharing the evidence with them, and also, going back to basics around, we need to make sure that, the local policies and procedures that we are developing are in line with the latest evidence and research, and making sure that we are referencing that within our documents. And I guess the other big challenge for us is making sure that we're aligning what we do to accreditation and to the National Quality and Safety Healthcare Standards as well. And that can be a really big driver for us in terms of engaging people on that journey as well.
Okay. When I was a practicing clinician, I'm a registered nurse. I worked in a hemodialysis unit. So plug people in, dialyze them for 3.5, 4 hours, depending on their status, unplug them and then get them back 2 days later to do it again. I was a good nurse, I suppose, in the sense that I was always washing my hands, you know, maybe 14, 15 times a shift. And then you notice that your hands are breaking down, and I thought it was the paper towel. So I went to the library after my shift, not during my shift, because you never get time to go during a shift. And I looked up papers on hand care, and at that time, there was a paper I found that said you can use warm air dryers instead of paper towel, and you get reduced cracking and bleeding in your fingers, and it reduces risk of transmission of infection, nurse-patient or patient-nurse. And I wanted to change practice. So I brought that paper to handover, and I read basically the abstract of the paper and said we should throw out paper towel, we need to buy some hand blowers and, you know, look after ourselves so that we decrease our own pain but also decrease the risk of infection. I made maybe only 30 mistakes in that approach. I assumed that one paper was evidence, but there's loads of papers and they all said different things. And I didn't manage my messaging at all. So I got everything wrong as a clinician in thinking about how do I change a practice based on what I think is a good idea. Adam, as an extension of that question that we've just had, how can a clinician sell their idea or their initiative to management so that there's potential for it to become an organisational reality?
Yeah, that's a great question. I think your approach, at least you went for it. You started down the path. I think the important factors are what's the outcome? What's the goal of the change we're looking at here, and how is that going to benefit our patients? How is it going to benefit our staff? What outcomes? How is the data that we're going to measure that collected? Is that data that we're collecting reliable? Right? Because it's we have to move past the perspectives or perception type of metrics when you're trying to implement something large and move to metrics that actually will be valuable to the management. So I think whenever we're trying to implement something new, we often start with the most senior leaders to say, listen, before we put a lot of resources into this, is this something that you support? Here's our proposal. Here are the metrics that we believe it will improve. And here's our timeline. And then we move forward based on that. So I think utilizing that approach and utilizing the fact that you can show that there is strong evidence to support whatever change you're looking into. Sometimes there is and sometimes there's not. And perhaps later we can talk through a little bit more about how you have a culture of evidence-based practice and still allow for innovation when things haven't been fully proven or there haven't been formal research studies to prove one way or the other. How do you stimulate that? And I think a lot of that can come with having a well thought through proposal with a lot of structure around how you're going to measure success.
Pre-planning. What about for you in the room here? If you're been through this experience, have you had this experience? Do you have some thoughts about pre-planning for implementation or message communication? Can we have a microphone, please, to Alejandra?
Thank you.
So would you please introduce yourself before you?
Alejandra Piñero de Plaza from Flinders University, postdoctoral research fellow, knowledge translation. Very long, that's it, time off. So I got a comment based on my experience in marketing science. And I have seen very few points that I think are relevant. We are focused so much on evidence because we are scientists or clinicians, and that's what matters to us, because logically it makes sense that that will improve using the Dwyer or the towel that you were talking about. But there is evidence in terms of communication and marketing science. They talk about a little bit of the heart first, and then the emotion, and then facilitating behavior. So one thing is the evidence that we have to guarantee the workout and is sound and strong. And another thing is selling this product to our audiences, which could be policymakers, educators, and so on. So what marketing science and behavioral science, and we got an expert there in the panel, talk about is first emotion, then convenience. Very easy to use in psychology, they talk about fluency. So it's something that you don't even think about. It's like a habit, and someone else mentioned that before. Then noticeable, attractive, and after return on investment. We were talking, oh yeah, you have to demonstrate that you're saving money. Yeah, all of that has to be there. That's the basis. But the most important thing, like we heard before, hearts, emotions, convenience, habits, how this has been done for ages here. Do you think you're going to come today with this fantastic, very return on investment? What happened with products? How many products do you have in supermarkets? They can be even better, healthier, and whatever, but you don't buy them. Why? Because they are not fluent, they are not noticeable, they are not attractive, they don't form part of your habits. And that's what we have to do, and that's why we have experts, like we have focusing on that.
Yeah, thank you. Thank you very much. It's an interesting move into thinking about behavioural science and how our choice environment predicts our behaviour as well, isn't it? Yeah. What about for you in the audience? Let's do a quick poll, just because you're all postprandial now and we need to know that you're awake. Who feels that they could, at this point in time, sit down and write an implementation proposal for a hospital or health system or service? Pop your hand up if you're 10 out of 10 confident you could get that.
Tumbleweed.
Just wiggle your fingers if you're awake. No, I can see. But it's challenging, isn't it? Like, I think we actually have a room full of fairly talented, clever, articulate people here. But these are big challenges to think about. How do we put something together that meets a need, that communicates the right kind of message, and does so in a way that will move others to join us on a particular journey? You know, those are skills that were not part of my undergraduate training, although I'm sure things have changed.
That point briefly. I worked as an exec director in the NHS, in a large 1,000-bedded system. And when I took the role, because I'd been in research, education practice, and the CEO said to me, you get paid what you get paid because of the pressure you will be put under in a sustained way. There was no breaks ever. The job description didn't have number of hours worked. It was what is necessary to fulfill the obligations of the contract. So, and she was absolutely right, you know, never worked more intensely, but also it's a different lens on the world, because it is a much more complex, and that was a big striking difference between working in academia as a research fellow and working as an executive director, who was also the clinical director of the emergency, or a couple of emergency departments. So when it came to writing board papers, it was a very different skill set, a very different lens that needed to be applied. Because we were creating policy all the time within a policy framework from the National Health Service, which would shift. We would get and you know, this happened in research as well, you'd get a call at midday from, you know, from the centre to say, we need to offload some funding, we need you to put in a proposal to do this piece of work. You just create some sort of nonsense and throw it in. I'm sure that would never happen in research in this country. But you're dealing, you have to be really nimble. I think that's the key point. You don't necessarily have time to think it through, because that's a luxury you don't have in the sharper end of both strategic and operational policy development and performance.
Yeah.
And when you're trying to influence boards, you have to think in their world, be them, not you. I think it's also for what are they thinking in this?
Yeah.
How am I going? So you saw Lesley going. She's got a board meeting this morning. She's going to have to be in a very different headspace to deliver the big and small political complexities of a board.
Yeah. Sorry,
Oh, I
Colin?
was just going to say, I was actually quite happy to see that nobody raised their hands just then, because I think for me, if somebody said yes, they were willing to write a proposal right now, right here, without actually engaging with the people who were going to actually be doing the implementation, I think I would be more upset with that. So I think that was excellent that we got a 0. Well done.
Sorry, can we just wait a sec? Can you get a microphone and introduce yourself?
If you missed it at the start, I'm Zoe at JBI. Brian, you've just hit on something that perhaps some of my colleagues will eye roll a little bit, because I bring it up all the time, and it's the role of empathy. And I think whether you're in a caring position, caring for a patient, whether you're in policy, whether you're a clinical director, no matter what your professional role is, I think that there is a critical role for empathy in all of the things that we're talking about. And I'd be interested to hear what all of your opinions are on that. Although I think I've heard yours now.
Carolyn, would you like to speak about
Yeah,
that?
I mean, I think I totally agree, and I think it's empathy, it's understanding where the person you're trying to influence is, which is being realistic about their constraints, and changing your perspective to try to understand the perspective of the person who you are asking to change. And I think that applies universally, really. Yeah.
I would agree with that completely. Like I think that in order to be successful, you have to work with all different kinds of people. You have to have an understanding of where they're coming from, what their needs are. I think to be successful, you need that understanding and empathy and emotional intelligence of other people for things to work. So
It seems obvious, but we don't talk about it.
Yeah.
If you look at the literature, particularly around implementation, we do not talk about it.
I also think there has been a huge, the focus really predominantly has been on the evidence for all these years. It's on evidence, evidence, evidence. You have a look at where energy's been, there's around synthesis, we see there's multiple methodologies on how to synthesise, which is all very important. And I'm happy to now sort of see that there is this shift to sort of more, okay, we've got all of this evidence, but it's not enough. Like before it was, we don't have the evidence, so therefore that's why we're not practising, doing best practice. Well, we've got evidence now in a lot of range of areas, particularly the slide that Lesley showed this morning, like asthma. There is a lot of evidence in the field of asthma. So it is very clear that there are other things going on that we need to have a look at. I think we have a high-level understanding of what they are. We know it's leadership, we know it's culture, it's change, and context is different for everybody. But we do need to invest more time in all those areas to have a deeper understanding of what it means, and sharing that with everybody. Like events like today, I think are really crucial, because we can share our knowledge and share our understanding. And if somebody walks away thinking, oh, that might be able to look at that for my area, I think that is great.
Yeah, thank you.
Very quickly, I'll just say this very briefly, which is that compassion is a belief system, whereas empathy is a skill set. And we need to focus on building that skill set. Sorry.
I hope someone wrote that down. Ed?
Along with all of his other quotes today.
Thanks, Craig. Ed Aramataris, JBI. It's just touching on a bit of what quite a few people have touched on, over the last few comments. And I think the first part here is, Craig, in answer to your question, could I write an implementation proposal right now? I could, but it wouldn't be a good one. And I guess...
I knew that, Ed.
Yeah, thank you. Because I know what I'm talking about, we all know that. And I guess that it really touches on, we saw this also, I think we wind back a year, when the world was hit with a new virus. Health systems had to respond. We had no evidence in relation to this virus, and experts made different decisions. Some went towards herd immunity, some went the lockdown pathway. And also listening to what Adam mentioned about where there is no evidence and having a plan. We talk about change and behaviour change. And when I think about health, the myriad, the gamut, the scope of decisions is enormous. From one end where it might be life or death, right down to the opposite end of the scale where it might mean that you know, someone walks out with a smile on their face instead of feeling a bit sad. But in all of this change, how do you build in that opportunity for failure, or where there's that risk of failure? How do you manage that? So I think it's a real thing, but I can't wrap my head around it. I think it's something that's hard to do. I'd like to hear your comments.
I think Adam might have a good response to that.
I feel like you're leaning forward for a reason.
I will give an answer, but obviously I'll be more than happy to defer to Kate. I know absolutely there's an answer I always gave, but certainly Adam and Kate might wish to.
Adam?
Sure. I think it's a great point, Ed, that we don't want to stifle risk-taking, because it's with risk-taking is where we see improvements, where we see creative solution-making. And I think part of, to circle all the way back around to Zoe in bringing up empathy, I think understanding where the staff are, I'm speaking in terms of the hospital staff because that's my context, understanding where they are at and what they can handle. And you know, our teams are tired right now. They just battled through a very intense year. So if we tried to just implement change after change after change, even if the evidence was supportive of it, it would be extremely challenging to push through. At the same time, we want to try and keep our teams engaged in their practice. And often one of the tactics we use is to engage the patients or the clients and actually empowering their voice in the story. And we have a lot of patient advocacy groups where we have current patients, former patients. We will have meetings around a change implementation and try to get patients who are currently in the hospital part of the group making the decision on should we do this or should we do this in one way or the other, because their voice tends to be what hits at the heartstrings of why everyone is there and you know what brings people to work, what fills up their cup with the passion for the work they do. And sometimes that can get lost with the busyness of and the complicated nature of the work that has to get done. And oftentimes when we can take a moment, step back, meet people where they are, acknowledge the fact that we're all exhausted, tired. We've never had a year where we had to run this hard. We talk about the amount of change that went through in my current organization in the last year buried the amount of change that went through in the last 10 years. We were implementing a new way to manage COVID patients basically every 2 days, and there was very little evidence to guide us. And we empowered the staff to be part of the decision making. We're like, how do you think we should do this? And got them involved with it. We even talked with the patients who were there and saying, do you think this would be okay? You need to challenge us if you see things that you think may not be appropriate. And I think finding those nuggets in to keep up the not only best practices, but to help people think that they can take a chance and know that certain types of failure are acceptable. You know, we often teach, you know, fail fast, fail hard, learn from it, and let's move on. And I think sometimes without the safety net that you feel that you may or may not have, sometimes you won't get those really, really strong nuggets of innovation that will help improve care.
Thanks, Adam. Kate, do you have some reflections on this?
Yeah, thanks, Craig. I think my comments are very much in line with Adam. Like, we have done a lot of different implementation projects throughout our organisation. You know, some big organisational change, some smaller local projects. They're not all a success. And so when we talk about implementation, and when we're promoting the use of evidence in practice, we do it from a perspective of this is about building capability and building the capacity of staff to be able to have that confidence to use evidence and to know where to go to get evidence, and how they might begin to make some change to their practice when they see a problem. So we're very much promoting it as this is for the individual, this is an opportunity for you to learn and to develop, and it's going to be a skill that you can come back to and that you can continue to integrate into your clinical role. And I think that's where we see a lot of success from the types of education we do and the types of projects we do, and how we can integrate that at all different levels from, yes, let's look at local policies and procedures and where we can make a change and align them to best practice, to smaller projects around, how can we improve the care for patients in, our local cancer setting and things like that. So, and much like Adam, we are, we're promoting through all of those programs and education, we do the importance of the patient perspective and consumer involvement and talking to the patients about what you're planning and what you want to do, and sharing that and using that feedback and that comments from patients and from our consumer groups as well in helping to shape the change and what that might look like.
Yeah, thank you, Kate. Brian, did you want to?
Something I used to say to my team constantly, you can't just say it once, you have to keep saying it again and again, which is, and this is in my service improvement teams and the emergency teams I was leading, which was, if we only make 20 mistakes today, it's a good day. Now, the subtext of that was, these are not women and men who go out to make a mistake. It was about fostering a culture where they were safe to have a crack at stuff. And often it would fall over, but the real trick, I think, when encouraging people to fail is when it fails, you have their back. Because psychological safety is the determinant of a successful team, where people feel that if it goes wrong, people have got their backs, but there's also people who will call them out, but they feel safe to call them out for doing stuff, because that's what makes a team successful. That's what keeps to take an example from sport, the All Blacks and the Wallabies, what they do is when they are at their best, they're driving their own performance culture, because they want to be even better. But what they'll do is they'll constantly try stuff, which is why you see these tries that are scored and thinking, man, that's gold. Because they try and try and try and fail and fail and fail and then have a go again. So I think that's a really important part is that psychological safety. Yeah. That is safe because people don't go to work to harm people, but they need to feel it's safe to have a try at different things.
Yeah. I think that segues beautifully with what Lesley was telling us this morning, wasn't it? About moving to, if you want to transform your health system, you don't create a logo and a catchphrase. You work with people, because implementation is not a technical process, it's a human innovation. And so you've got to create the capacity for people to have safety, support, and be able to take a risk in order to see what will happen. So those are really key things. Taking a risk does mean, if it doesn't work, you might lose momentum. I'm just wondering, from the floor, there's two ways maybe you can lose momentum. One is if something doesn't work, and the other is that key members of your team get removed from your team because they get allocated to COVID care or something else, and so you have staff turnover issues as well. Is this something that's been a challenge for anyone in the room today? I'm seeing a nod. Does anybody want to share a quick story about that? I'm not looking at the person who nodded because that might be intimidating. All right, so...
Is it about losing momentum, or is a bigger fear losing face?
I would be scared of that. Yeah.
Because people, when you put yourself out on a limb and it fails, the risk is you lose face. And I think that's what people fear more than losing momentum.
Yeah. Kate and Adam, do you hear this ever? Do you have to grapple with this issue that you might want to work with daring clinicians, but maybe they're scared of failure because they might lose face? They don't want to be a failure.
Yeah, absolutely. I mean, I've actually seen a few implementations just fizzle out because they lost their passion because they met some resistance initially, and they were scared that if they kept pushing, that they would be perceived as one of, a little bit out of touch with what is really happening with their colleagues. I'll say one strategy that we are trying to push more into is being transparent and highlighting, almost celebrating the failures, to show that that's okay. And saying, you know what, this project didn't work and I want to do a poster about it. Because it's not sexy. I didn't show any good outcomes, but I followed a process that, just didn't show improvement. And, next time we'll do it in a different way. And I feel like if we do that more, the concept of failure won't necessarily be perceived as a negative. If you did it in a systematic way, it'll be perceived as you went for it, you tried, you didn't get the air blow dryers in, but next time we'll learn from it and take a different approach.
Adding something there. I also think, just hearing that, it sort of leads out that having regular like I come back to communication, but that regular communication, that regular checking in with everybody. So you're not just going to try and implement something, change a whole statewide practice, do it once and then never check in, reevaluate. It's the constant checking in process and looking at what's worked, what hasn't, and not only, I guess, celebrating the failures, but the small successes, I think, as well. So it's not just the end point of did it work, did it not? Okay, it was a success or failure, but looking at the smaller little bits along the way, I think that's where we need to be focusing on as well.
Kate, would you like to add anything at that point around fear of failure?
I would, just reflecting on what Adam was saying, one of the key aspects for us in terms of our program and how we approach implementation is mentorship. So really being able to have some support there for people who are trying to make change, and somewhere where they can come and talk about any of the issues that are coming up or the challenges that they've had in practice, because most of the time it's things that we've heard before. There's no leadership support, or, the culture is not open to the change. And, so they're things that we can sort of talk through and address. So that's been a really key aspect for us, just, having a mentor for them to work with, and also just having those networks where they can come back and share. Because, often when we come back as a group and we talk about where we're at in terms of implementation, they're all seeing the same challenges. It might be in a medical ward versus a cancer setting, or even in a neonatal critical care unit. The challenges are very similar. So being able to have that support network is really important in getting them to continue and driving change.
Thank you, Kate. Earlier you heard Carolyn talk about the pressure to publish as an academic, and that's part of your survival. When we fail, there might be a fear that this won't be able to be publishable. But recently, JBI Evidence Implementation, which is an international peer-reviewed journal with a strong editorial board, a good impact factor, quiet side plug, we published an implementation report where out of 7 criteria that they were trying to improve practice on, they improved practice by 15% on one criteria and not on any of the other criteria at all. But it made it through peer review, blinded double peer review, fairly easily, not because of the significance of the results, but because of the significance of the learning experience that individual went through in engaging with their organisation to try and initiate a change process that later we found did not work. But they unpacked that whole process of how they engaged with who and why, and they dealt with that across all the spectrum of leadership, because hospitals are horizontal and vertical, and you've got to get your communication going horizontally and vertically pretty much at the same time, using the right language for those groups. Otherwise, bits of it fall off. And it was a really compelling piece of work, actually. But if you look at it based on outcome data, it was a failure. But in fact, what we all learned by reading that manuscript was really deep knowledge about how expert clinicians can successfully engage and develop their knowledge of their own organisations. And I actually think a lot of us, like I was an incredibly naive clinician. I had no idea how to talk to a manager. So these are important learnings that can come whether or not we characterise them as success or not.
If I can just add, I also think too that, you know, we talk about that the setting the culture might not be ready for change. It might not be ready for the change of that particular project, but clearly some other kind of change is necessary then, because if the culture's not ready, then that in itself needs to change. So I think that's just an interesting.
It is a good point, isn't it?
There is a threat at the moment as well, of course, because journalism is so much pressure and they've got so many papers being submitted to them. And I can't remember, is it UK or US Pediatrics, about 18 months ago said, we will no longer accept qualitative studies. And that seems to be a growing issue in terms of publication. And BMJ is the BMJ Pediatrics Journal, was it?
The main BMJ journal.
The BMJ journal.
Yeah.
And I think that constitutes a real threat because quant is great, it's valuable, but there's two sides to the story. And people, it's a great US poet, Rucker, who says the universe is not made of atoms, it's made of stories. And it's the qualitative, the story-making, sense-making that people are, that's a richer story for often. And that often, I think, probably has a bigger impact on practice than all of the numbers under the sun. And I was lucky enough, I went to Oxford University, and at New College there was a guy called Justin who was a Rhodes Scholar from Australia. I think his PhD was 54 pages long, doing maths. And he said to me, you and I, because I was doing an educational master's degree, he was doing a PhD at DPhil in maths. He says, you know, the two of us are we're actually the same. We were both junior deans. We're both storytellers, because all scientists will ask the same story that a qualitative researcher will say, what story is the data telling us? He says, whether you're a physicist, an astronomer, a mathematician. And it was one of those great big aha moments in my life as a researcher. It's all about the stories.
Okay, thank you. Can we get a microphone to Susan?
Thank you. There's such a rich discussion, and my brain just keeps thinking of all these different examples. But I just want to pick up on the issue around how ripe an organisational culture is for change. I think that we tend to think that change is the answer to everything, and if people are against it, they don't want to play by the rules, and I think that's a really dangerous environment to be in, because the reality is every day when a clinician comes to work, they work within an environment of change. Their patients change, their scenarios change, the doctor change. They're in a constant place of change. But what I have seen, and I've been in the health system for many years myself, is that actually clinicians have no opportunity to embed the change deeply. They're given little bits, run with it, tomorrow something else, government change, something else. And in fact, people are questioning why, what is the value, what's the benefit for the patients, are we changing, what is actually the purpose of the change. And so, like any good sports person who has to practice and practice to hone their skill, the very thing we don't give clinicians opportunities to practice and to embed and to get really confident about what they do. We just give them this sort of piecemeal stuff. So I think, you know, taking from what Adam and Kate and everyone is saying, yes, people need to have the opportunity to take risks and to be comfortable, to be celebrated around that. And Craig, absolutely right. The literature, even publishing, is biased against publication that have where the intervention is not positive. And we know that already, you know, in many fields. So all we get in the literature is about what apparently works, but we don't hear a lot about what doesn't work, which would help, you know, as well. But we also need to not think that people who might not go on the bandwagon, that they're the ones who put on the brakes, because I think they might be actually the ones who want to do what they do well. So I think we just need to be careful around, again, the language and the thinking. And as Brian said too, we need to give people opportunity to unlearn. So I always say health is like a big USB. We just keep on uploading information, but we take nothing off the USB. And so people are overloaded, overwhelmed, and tired of change.
Yeah. Thanks for that comment too. I mean, maybe I'm trying to find a really clever segue and I can't, so I'll just say the question. This comes from Dr. Jude Tabin from the Philippines. If you're online, then here we go. This is your question. Did COVID and COVID research teach us anything about the connection between education and the organisation and delivery of care? Do you feel like we've learnt lessons from managing COVID in terms of the way we educate and prepare clinicians? Sorry to do this to you.
I can't really answer that. I think because I don't I don't have experience in that world and in that space. But I mean, someone else might be able to. I can talk about evidence for COVID, but not the.
Yeah, I'll throw to Adam first then. Adam, in UCSF, do you feel like we've learnt those lessons in terms of how we educate in such a way for uptake into practice?
Absolutely. It was a constant learning for us. And, especially initially when we were converting units to care for, 100% COVID patients, and the workflows that we were doing without good evidence on and best practices, and we were creating it in the moment, totally changed how our typical structures for rolling out education, at least on the direct practice side. We were doing just-in-time creation of best practice and then whipping it right back around and doing just-in-time training for the person right next to us. And that was, it was so fluid and at first very chaotic. And then the staff understood this is the situation we're in, and they learned to trust it. And so it really taught us the power of having the right people doing just-in-time training in the moment that staff could trust. And when it came from a reliable source, that they would go with it, because there wasn't an extensive amount of time for every single individual to test it out on themselves. We sort of had to just push forward. And that was a unique situation because typically we get to do a little pilot in one area, test it, measure it, maybe make some changes, and then do a pilot in another area. That was not the situation over this last year. We were just having to make very rapid decisions. And because of that, we got used to finding out information right before we were walking in on how we were supposed to do something. So I think we learned a lot of lessons with the urgency of how we had to provide care.
Like at Mater's a large, disparate group, really. Was that a challenge, trying to connect education and development of staff for care provision?
Yeah, absolutely. I mean, we didn't have the same challenges with COVID that Adams has seen in the US, but, it certainly, it required a lot of different approaches to how we do different things. It also came at a time where we were becoming this sort of multi-site organisation, bringing on other facilities across the state. So, very rapidly we, had to utilise the resources that were coming out, all of the different evidence that was coming out, being able to pull that together quite quickly for our clinical leaders who were sort of making decisions about what we were going to do if we had an influx in COVID patients. We certainly saw the uptake of technology in how we approached everything in the organisation. So how we approach meetings, we went from having face-to-face meetings to everything being online. All of those kind of approaches, changed our whole approach to education in general and how that happens across the organisation. And then also coming together as sort of one martyr across the state, we realised where there were really big gaps in terms of education and rollout of equipment that we needed in terms of our N95 masks and, which site had access to, particular supplies, resources. So there was a whole range of issues that came up through COVID, and we've certainly learned a lot of lessons as well. And we've certainly learned a lot of more effective ways of being able to do things as well. And that reaches across to EBP and our rollout, and it influences how we can connect with staff. Like everything used to be around, it has to be face-to-face education and it needs to be, in certain clinical time. And now there's just so much more access to technology. Everyone's on Teams. Meetings and education can all be online now, and that has really just opened up our access to be able to connect with people in a lot of different ways.
Okay, thanks, Kate. I mean, one of the motivations for education, particularly within an organisation, so not the undergraduate program, but specialist education you might do within a hospital, is really to help drive the coordination, the organisation and delivery of specialist high quality clinical care, but it can also be used in a short course format to encourage uptake and use of evidence-based practice in an institution. But there's always that challenge of organisational leadership, because without organisational leadership driving it, to be honest, and we talk about top-down versus bottom-up, and there's quite varied views about that, but without organisational leadership, it's not really going to happen, is it? So how do we strengthen organisational leadership to encourage uptake of innovation, change, evidence-based practice, whatever word you want to call it? How do we strengthen organisational leadership to make that, to enable more of that in our systems?
First thing, counterintuitively, you don't change the leadership every couple of years. Central Adelaide went through 10 CEOs in a decade. Lesley's now here 2 years. She's almost on long service leave. I work I've got a 100-day annual contract with Canterbury District Health Board as Director of Service Improvement. And it's one of the top 5 most integrated health systems in the world, alongside Kaiser Permanente, Intermountain Health in the States, Salford, and I can't remember the other one escapes my head right now. And they had an executive leadership that had been there for the best part of a decade, all of them, There's been ructions in the last year for a whole bunch of reasons, and 7 of the 11 left because of very poor governance, among other things. Really outstandingly good people. Next year, all 20 district health boards and all 30 of the PHOs in New Zealand will be abolished. And as NZ, New Zealand moves towards an NHS model, at the very time the NHS is moving to look to integrated care systems that New Zealand does. Because structures don't change. Structure is your anatomy. Process is your physiology. And your process also fits in the people bit. That's your physiology. So having a stable leadership is critical, because what that comes back to is trust and empathy. If the average tenure of a CEO in Australia is around 19 months, and it's a double loss for 2 reasons. One, If you don't like the CEO, keep your head down, they'll be gone in about a year and a half. If you do like them, what's the point? Because they'll be gone in a year and a half. So it's a lose-lose in healthcare. And you need them to pay, because you only build trust, and organizations only progress at the speed of trust. So capability, leadership, all of those things, the foundation stone is trust. And that takes time. Because I'm not going to give trust to somebody, some random I've just met. I need to know what they're like, who they are. Is their lived values the same as their espoused values? And we've got outstanding BS detectors, all of us. We know when people are speaking truth and when they're speaking the other stuff. We know it's how they actually behave, and we will be watching them always. And what I say to leaders constantly is, you're not off duty for a heartbeat. Because how you behave to the person who serves you the tea and coffee and the sandwiches, somebody sees you. You're not off for a heartbeat. So the role of leadership in sustaining successful change, it's as much about your behavior as about your qualifications, your integrity, and everything else. It's about your decency.
Yeah. What about from the floor? Does anybody want to be really, really daring? You don't have to stand on the table and say, "Captain, my captain." However, do you have some thoughts around strengthening organisational leadership to promote uptake of evidence-based healthcare? Can we get a microphone, please?
Just listening to Brian again and thinking about trust, about improving and the language and how we refer to error, and going back a little bit about failing and the recognition of failing within the clinical and research environment. So if we think of a parallel situation, we have it in technology. So people in technology, they don't go and say, we're totally wrong, that's it, this machine doesn't work. What do? They have a process of optimization, they're cyclical. So they don't talk about we fail, they talk about opportunities of improvement. Those opportunities of improvements are barriers. So just small barriers, and then we understand. If we fail, this is not publishable. No, we have opportunity of improvement, and this is publishable because we know where to go next. And if we think about that in terms of leadership, then perhaps if we have a system where trust is kind of automatized through opportunities of improvement, then we have a leadership that feel like progress. Like you were saying, the connection between progression and trust. If you are within a system that is constantly optimizing itself, not finding errors, then you have more trust and better leadership. Is that a theory?
No, thank you very much. Good.
I just think it's interesting because it seems to be sort of like a lot of common themes between everyone's comments. So, you talk about trust and having consistent, reliable people in leadership, and we're talking about having. Adam talked about what worked for them was being able to have trust. The person trusted that they could deliver the information, and that's what you were delivering is exactly, synthesising it, and that information was trusted as the evidence source. So I think, it's interesting that it seems to be like a core component that for implementation to be successful, we need that trustworthiness and reliable, that we can sort of count on each other to be able to move things forward. So it was just more of an observation than anything else.
So sometimes the messenger is the message, in a sense. Yeah.
And if you don't mind, if you look in the recent politics of the United States with Biden and Trump, the messenger is the message.
Yeah.
For good or ill, I make no judgment.
Right, now for your academics in the room, you're going to love this question.
I'll get my coat.
This comes from Dr. Alabdani, who's a postdoc research fellow at University of South Australia, Adelaide, the best city in Australia, with the best wine districts in the world, even better than California, Adam. So, sorry, the question is there value in adapting and designing implementation science frameworks to increase translation of evidence into practice for specific fields of inquiry? And are there methods that could help increase this translation? So I'm going to segue from that to say, Brian, we talk in implementation science, translation science, knowledge translation, we've got all the lingo, and we've got more frameworks, models, and theories for implementation than...
Throw a stick at.
Exactly, than you can throw a stick at. What's a consumer to make of all of this when they walk into the hospital system?
They wouldn't have a clue. Not a foggy. You know, what is triage? That's the first experience you'll often have in an emergency department.
Yeah.
And what is the otolaryngology? We have a lot of TLAs in healthcare, do you notice? They're three-letter abbreviations, you know? Like, what is ENT? I mean, does NAD mean no abnormality discovered or not actually done? You know, we use this linguistic shorthand, which completely bamboozles even, you know, people who are pretty smart. So I think that's one of our big challenges, is how do we make it simpler without being simplistic?
Kylie, are we just making language complicated to make ourselves sound more impressive?
No, I think, to go back to your question beforehand, though, around all the different models and frameworks, I think what that shows is that implementation is complex and complicated, and there is no one model that's going to fit everybody globally across the world. So I'm okay with there being lots of different models and frameworks, and I think at the end of the day, if people can adopt something from that framework or model and something from that, and it works for them, that's what we should be going with. I'm not sure, you know, we try to sort of encompass everything all into one little pretty picture, and you can't do it. I mean, we've seen what implementation, when we look at them, you know, people are delivering presentations on it, it used to look nice and linear, and now it's this squiggly line mess because we know it's complicated. Yeah. So I don't think we're going to ever come to sort of an easy answer around it. I think it's just more identifying what the challenges are for us.
Wasn't that with the great W. Edwards Deming? I loved his line, which is, all models are wrong, some are useful.
Yep.
Yeah, that's a great
Except
saying.
for the model that the JBI.
Of course.
That's the one.
And Adam and Kate, obviously.
Yeah. Couldn't agree more. Zoe, thank you.
Craig, I think that's a really interesting question about the consumer perspective on all of this, because we've all been at this game for a very long time now. You just don't know it because I colour my hair, but really I'm the same colour as Craig. So we've got a lot of experience, right?
Like mine.
When I first started in JBI 20 odd years ago, my dear mother, who's now in her 70s, used to say to me, she knew a little bit about what we did, but not a lot, but she used to say, when you go to work, can you just ask your nurses about this thing, this problem or whatever? She knew I worked with nurses, but that's about it. As she got to understand what it is we do, she started to ask questions like, can you look up the evidence for? And I always found that, and still do find that, a really interesting, you know, evolution in her thinking and understanding. Because as somebody who has never been a clinician, I don't have a clinical hat to put on, I still remember being quite astonished when I started working in this space that this was even a consideration. What do you mean health professionals aren't using evidence or don't know the evidence for something? Because we put them up on, nurses, doctors alike, put them up on this pedestal and assume that they know everything about everything to do with this and what goes wrong. And I would hazard a guess, I know it's 20 years later, but I'd hazard a guess that most consumers would still be quite astonished at some of the conversations that happen in these rooms, talking through some of these challenges. Because I think that there is an absolute naivety about the challenge associated with evidence-based healthcare and the knowledge of, you know, nurses and doctors and other allied health professionals.
Yeah.
But I think, you know, it'd be interesting to spend more time thinking about that, going back to, you know, we're talking about people, caring for people.
Doctors especially, they're the secular priests in a modern age where religion is being replaced, and we deify them. We have the voice of nursing has certainly been amplified in the last particular 18 months. But you're right, I think, you know, and you know, Kylie and I would agree with you. People will be shocked. But also, particularly as nurses, we're often used as navigators and we're translators. So patients would ask us, what did the doctor say? So we speak medicalese and patientese with ease, and our role is the navigators. And also in the family, you know, as a family nurse, of course, I was the one who was navigating. You get family members coming up to you and say, can I show you my rash? And you say, well, not on the dance floor, if you don't mind. That's kind of your life, you know.
It is, isn't it?
And I think it's something about, there's something other about that language, and we need to deify, because it's about something that is mystical and mysterious that people don't understand.
Yeah.
And maybe that's something in it. Maybe we shouldn't knock it too hard, but certainly we could benefit from being more humble as well.
So we should shake the tree a bit, see what fruit falls, but maybe not pull it down. I mean, Adam, you run 2 implementation programs really targeting engagement with clinicians. Is there a story there about the value of models from a clinician perspective? Is implementation really complex for a clinician, or is it more instinctive and intrinsic than that? And are models not so relevant at all?
Yes to all of that. I think before a clinician really gets into a complicated implementation, they don't really know all of the elements they're going to encounter. And without some structure, some model to guide them, they can easily veer off path and, you know, can hit some barriers that may be able to have been prevented. So like Kylie said, there's no one secret sauce. There's no follow A and B and you will always get to C. Like that doesn't exist, mainly because of everything we've been talking about. We are dealing with people and the readiness for change and culture and, you know, how strong evidence is and all of that. That being said, the majority of clinicians, and to Zoe's point, the majority of the consumers have no concept of what these models are. And sometimes that's okay, especially the clinicians in their busy world. They've got plenty of stuff that is taking up their cognitive load. But if we do, and I think some of the successful programs that we've been running through implementation in a formal way, where we do have structure and we do have it based on models, help guide the clinician in the implementation process. You know, even just thinking ahead of time, here are some barriers you may come across. Let's think about them way before you come across them. Because ideally, if we think through them enough, we could potentially avoid, you know, the barrier altogether. So I think there is I think that, yes, it is very complicated, especially if you're trying to implement a change that will have any impact on time of your colleagues. If you're trying to implement anything that will increase the documentation or be perceived as unnecessary, there are major obstacles that you have to overcome, and those can be very complicated.
Great, thank you. Our next question is from Dr. Kibibi, who's an associate researcher for the Ethiopian Institute of Public Health. in Ethiopia. And he asks, what are the strategies to create awareness amongst policy decision makers to use evidence before making a policy decision? And I'm interested in this. Years ago, I went to a policymakers conference where one of the speakers was a social science researcher who said, policymakers use evidence the way a drunk uses a lamppost. It's for support, not illumination. But I feel like that's been challenged today. Like listening to Lesley talk, listening to your talk, Carolyn, there's a lot of engagement around evidence now. But I think the question is still worth teasing out. So is it awareness amongst policymakers that maybe they should think about evidence, or are we just unaware that they're already deeply invested in evidence? And is that a gap? Is that gap a problem?
I think it probably depends on the policymaker, to be honest, and I think that there's probably a lot of variability. I mean, one of the things that first came to mind when you first asked the question was, if you're not in agreement about we should base our policy on evidence, if that isn't a fundamental shared starting point, then start with values. You know, find shared values, because, and that's often how we sell policy. I mean, you've talked about stories being everything, and stories are everything, and that's how all sorts of individuals and agencies propagate their agendas in society. So I would say meet the policy maker on shared values. And it might be, you know, if you're working in child health, it might be about, you know, there's a sort of universal right of a child to have an open future. You know, in Australia, we have particular values that we draw on all the time that resonate when we're speaking to people. So that would be, I would say, the entry point. And you know, put evidence in your Trojan horse. And absolutely, people like to depend on evidence when they're selling policy. Yeah.
That is interesting, because I think having the value, it's almost like that should be the starting point. It probably should never be the evidence, should ever be the starting point. You really should have what it is that you're trying to achieve, and then look at what the evidence is saying. You know, rather than going in and saying, here, like what you did, here's the evidence, we need to change practice. It's not always one of the best strategies. It's having that shared value, or, you know, what it is, an understanding of what it is you're wanting to achieve, and then looking at what the evidence is saying.
Yeah. Let's do a poll, because I love audience polls. Put your hand up if you're confident you know the values of your leadership group.
It's always looking around at everybody. Everyone from JBI should have their hand up.
Okay. So it's a challenge, isn't it, actually, leaders to communicate their values and everyone else to listen and catch what those values are. Kate, I want to throw to you, because you spend a lot of time in coordination and management of significant issues. How do you start with considering values and shared values? Where does that come into the picture?
Yeah, I think that's really important, Craig. I mean, again, we've gone through some organisational change in the last 12 months. Our mission and our values has changed slightly as we've come together across one state. And I think the key with anything that we do, or anything we become involved in, is it aligned to the organisational values and priorities, and particularly for us, that's where we're going to get a lot of that leadership buy-in, if we can demonstrate that what we're doing is aligned to that.
Thank you. There's a question here about collaborative culture. Brian, much of your career has been about culture and collaboration. What are your thoughts on some low-hanging fruit on building healthy collaborative cultures?
70%, John Cotter found, he's a now emeritus professor at Harvard, found in 1996, 70% of change efforts just fail flat out, 25% limp along, and only 5% succeed. And the most successful changes, they have got high levels of communication, engagement, talking to people, listening to fears, trying to understand, all of those bits. And 20% is Gantt chart project planning detail. Unfortunately, in most change efforts, it's the other way around. One of the upsides of COVID is actually there wasn't time for a lot of that stuff. It's like, okay, what do we know? What do we do? Who do we trust? Who are the trusted leaders who will get this over the line because I can't? So I think it's about taking your ego out of the room and saying, who is the best person to do this? Yeah. And actually it may be the cleaner, the ward clerk, who might have more in common with the patients than the terrifying nurse, allied, or the doctor. Yeah. So who are the people who can lead? And leadership isn't a job title, it's a set of behaviours. And echoing the earlier question about values, most people don't know what the values are because they're very rarely lived. And it's, I've never come across a health organisation that didn't say it was patient-centred anywhere on the planet. But if a place was patient-centred, why do we have visiting hours? So, when it comes to the collaboration, the most untapped resource in healthcare are patients and their families. Why are they not part of the collaborative force for change?
Yeah. Thank you, Brian. For those of you that don't know, Carolyn Miller, Professor Carolyn Miller is one of the world's top public health researchers. We're blessed that she lives in Adelaide. I've just freaked you out, haven't I, by saying that? Because she lives her values.
World's a bit strong.
Runs highly successful multiple research programs. Culture and value have to be intrinsic to the way your groups run. How do you, given we have some academic research staff here today, how do you build culture and collaboration for successful research?
Yeah, okay. I mean, I think, I think culture and values is what you walk, not what you talk, definitely. And if you want to understand, a policymaker or someone else's values, you learn that by watching what they do and what drives them. I suppose what I do in my group and working, so I'm with SAMRI and also with the School of Public Health at the University of Adelaide. And one of the things I suppose that I've really enjoyed shifting into SAMRI as an organisation is it's an environment where failure is absolutely, endeavour is encouraged, and you want people, and this is something I suppose I encourage in my team too, I want everybody to be able to have the space to stretch and take risks and grow. And pursue something that's of interest to them, and then, but also I suppose there's an accountability. There's a very real accountability in grant-funded research around funding cliffs. So, none of us have secure jobs in grant-funded academia, that's for sure. Whereas in a kind of my previous life, which was in the NGO sector, there was a lot more security. But I suppose I don't want my staff worrying about that. That's what I think is my job to worry about. It's my job to take responsibility for people's job security and to give them an environment where they feel comfortable to, take risks and grow and be as adventurous as they can. So that's what I encourage, I guess.
Terrific. Kylie, what are your thoughts about this? You run an implementation team.
Sort of. Maybe you can come back in a year and I can ask you that. I just think culture is important across all fields, not just within teams, but within your research. I was thinking about your research unit teams. So obviously you've got the people who, for us, who are summarising the evidence and what our culture is like. But then you're looking at the culture within implementations. For me, you need I guess, a positive culture across all the different teams. So you've got your academia team, but also your clinical team, and then it's getting a shared culture between the two. But I don't have any simple answers on how to create that. I think, as long as you're communicating, checking in with people, taking critical feedback, learning from your experiences, it's all of these things, being allowed to make mistakes, and feeling safe and secure. I think it'll all go. So pretty much what everyone else has said.
Well, I think that's a great illustration of lived culture, and that's exactly what we're looking for, I think, in this session. Adam, can I just ask, what are your closing thoughts on culture and collaboration and how you strengthen those things?
Yeah, I completely agree with everything that's been said around it. You know, there's the organizational culture, and then there are the local area culture bits. And, you know, I see very frequently all the time where one practice setting has a different culture. We have an organizational culture, but then one practice area setting has a slightly different culture than another practice setting and another one. And when we talk to our nursing staff who float between them, they know how they need to operate on one unit because the culture there is so different than another unit. So to be successful there, they have to, and it's okay. Like we're not trying to make everyone the same, but where culture intersects with collaboration, all of the work we do as clinicians is collaborative. Like this is not an individual sport. We have to be collaborative. And so I think as an organization, the culture around collaboration is vital. And there has to be the venue, and there has to be the shared understanding that we need to collaborate with all of the stakeholders involved in clinical care.
Okay, thank you very much. Look, I believe we're out of time for this session, so I'm going to have to close it there. Would you please thank with me our guests who are here on stage today, and Adam and Kate from Brisbane and UCSF in California. We're going to break for afternoon tea now. If you've been live streaming with us, and then we thank you for your participation in this event today. Stay tuned for the next announcements from JBI Education for more really exciting online events later this year. For the rest of us, we're going to have coffee and a really good chat about culture and collaboration. So thanks once again. We've got afternoon tea now.